Bore da chi gyd, a croeso I bwrdd iechyd Prifysgol Aneurin Bevan. Welcome to you all, and welcome to this meeting of the Aneurin Bevan Health Board. We are being live streamed today, so hopefully we will have a number of viewers who will be able to find out what this organisation has been up to over the past few months. We have faced unprecedented times with the increase in the virus within the Gwent area, coupled with other winter illnesses. Staff have worked absolutely tirelessly to care for our patients in both the hospitals and in their own homes and in the community. There has been a magnificent effort by all staff and our volunteers to maintain our services, and there have been some difficulties which have been well reported. Following our discussion on the minutes and the matters arising, I will ask Judith to take us through the issues that have arisen, what is happening now, and what we're planning for the future, so that you, our public, will know exactly what is going on. We hope that you have found the communications that have been coming out from the organisation useful and helpful. We do wish to urge everybody to use our services because we don't want people sitting at home feeling they can't access them. They are there to be used. But nevertheless, we have faced some difficulties. But I'll now pass on to the apologies for absence. Richard?
Yeah, just one for today, and that's Louise Wright.
And Mez cannot attend.
Oh.
Okay, thank you. Any declarations of interest? No? Okay, thank you. Could we take then the draft minutes of the board held on the 23rd of September, which seems a long time ago, really? Are there any amendments to these minutes?
Yeah, there have been three, and I think they've been passed on to you a bit more about spelling rather than any changes.
So no substantive change?
No.
Fine. Or can we take those as read then? The action log, please. Richard?
Yeah, policy just coming up. There was only one action, and that was with the financial report, and that's been completed.
Thank you. I think there was also a change which we need to report on mental health consultation. We have had
to write in that, Dan.
Okay, right. Judith, then, if you could outline the current situation, would be helpful. Thank you.
Okay. Did you want to do matters arising from the minutes that weren't on the action log, Anne?
Okay, fine. Any matters arising not on the action log?
Anne, it's Shelley. It was just the point that you were just, I think, alluding to about the mental health consultation, because I know that has gone on hold. So I thought perhaps we ought to just have that noted in the minutes. And I understand from later on in the agenda it's due to be relaunched or whatever at the end of January.
Yeah, fine.
If Nick could come in, Anne, please.
Nick?
Yeah, thanks, Chair. Just to say we had some initial engagement conversations to set out really the full details around what we would be engaging with the public on from a mental health services perspective, which took place in November and earlier this month, which have informed a sort of slight adjustment to the engagement document that has now been finalised, and we will be taking that out from the first week in January.
Thank you, Nick. So we can be assured that everybody will have a good opportunity to contribute to this effectively.
Yeah, and we had to make some adjustments to how we were going to engage, and we've arranged a number of sort of virtual coffee mornings of meetings to ensure that we got the widest possible engagement that we could. And we've had a conversation with the CHC about how best to approach that on the back of some of the comments that we'd received.
Lovely, thank you very much. Are there any further comments on that? Any other matters arising?
I think Nicola might want to come in on the satellite radiotherapy unit and possibly the Medipark as well.
Thank you. Nicola?
Yes, thanks, Anne. So the Satellite Radiotherapy Centre, we were invited to Welsh Government's Investment and Infrastructure Board last week, which I attended along with colleagues from Council Dan Valindra. So we are now awaiting Welsh Government's decision as to whether that case will be approved to enable us to move to the full business case stage. It's a very positive session, so we are hopeful that that will be approved. And in terms of the Medipark, we have had acknowledgement of the strategic outline case that was submitted following the last board meeting, and we are now having discussions with Welsh Government about the next steps to enable us to get clarity about moving forward with that case.
Thank you, Nicola. I think that's all very positive news, particularly about the satellite radiotherapy unit, which will make such a difference to our communities. Thank you very much. Any other matters arising? No? If we could pass on to Judith's statement.
Yeah, thank you. Thank you, Chair. Just to add, just probably begin by adding to your comments really about paying tribute to the health and care staff who work across the Aneurin Bevan Health Board area. Every day I'm actually truly impressed with their commitment to our patients, service users and our communities. They work with compassion, professionalism and true dedication really to their role and our patients. And I think just to add my comments to those of yours, and really to recognise that. And of course this year has been a year like no other really for our staff and the staff working across the health and care system in our area. So it's not just about those employed by the health board, but people who work in primary care, people who work in social care as well, and the vast number of carers who are caring for people in their own homes. We know that the numbers of cases in our area has been rising. As of yesterday, we had 438 COVID positive patients in our hospitals, and another approximately 90 who were suspected, waiting for their test results. Got 113 patients who are recovering from COVID-19 and 874 non-COVID patients. So the hospitals are extremely busy. Our community transmission rate in the health board area is now at 536 cases per 100,000, with 3,189 new cases in the last 7 days. So we're seeing a continued growth, not only in the number of cases in our community who are being detected as COVID positive, but actually those people now who are coming into our hospitals. And for the last week, there has been an ongoing pressure and an ongoing rise, and our clinical teams have been telling us that the number of COVID cases presenting and the number of seriously unwell patients presenting to our hospitals has been of concern to them. Medical Director and I met with a group of our senior clinicians last Thursday and talked to them about what was happening and what action we might take as an organisation. Following that conversation, and in general reflection about the projected increase in growth in cases, so not just about what was happening now, but actually what was likely to be happening over the next couple of weeks as we move into Christmas and the New Year. The executive team determined, in discussion with those medical colleagues, that we should take action, and we took action on Friday, the 14th of December, to cancel or to give notice that, from Monday the 14th of December, we would cancel all non-urgent outpatient clinics, with cancer and clinically urgent cases continue. We'd cancel all non-urgent planned surgery as well, again with cancer service and surgery for clinically urgent patients continuing. There were some things that we determined should not be disrupted, so we thought that anything to do with diagnosing illness, so radiology, our X-ray services and our endoscopy services should remain unchanged, because clearly if people are worried about the signs and symptoms of illness, making sure they get a quick diagnosis and a quick test is important. And we haven't made any changes clearly to our child and adult mental health services, not wanting to disrupt those in any way, given the toll the pandemic has taken on our communities. So we've made that decision. We've said that we will review week by week, but with a formal review probably in mid-January. Clearly, our teams across the health board are still very concerned about the pressure on services. This wave of the pandemic is very different to the first wave of the pandemic. In the first wave of the pandemic, our hospitals emptied very quickly, and we had a lot of space in which to care for patients, but also we could redeploy staff into wards and into our intensive care. This wave of the pandemic, our hospitals remain very busy with both non-COVID and COVID presentations. And so we are managing quite a different demand on our system. And those logistical issues of separating streams of patients are very real for our staff. Every day they are trying to deal with making sure that our patients are cared for in the most appropriate locations. Staffing is becoming a real issue for us. Our sickness absence rates are now running at 11%. That is a mixture of non-COVID related sickness, COVID related illness, but also people who are medically excluded from work. And finding bank and agency staff, particularly nursing staff, who are able to provide extra hours or cover for them is becoming increasingly difficult. So it's a busy time, it's a worrying time. We feel we've taken the right action as a health board. It is in the context of a framework that Welsh Government did issue last Thursday, recognising that the NHS in Wales was under increasing pressure and just providing some framework by which decision making could take place. Clearly we as an executive team are monitoring the situation on a daily basis, receiving regular reports from the front line as to how things are and connecting with our clinical colleagues to make sure we respond very quickly to any issues that arise. So I just thought, welcome the opportunity, Anne, at the beginning of the meeting just to give an update on that. And I or the executive team would be happy to answer any questions before we move into the rest of the agenda.
Thank you very much, Judith. I think that was a very clear explanation of the situation in which we find ourselves. And obviously we apologise on behalf of the board for any disruption that has been caused to patients over the past few weeks, which obviously it's hugely regrettable, but I'm sure people will understand the situation with which our staff and ourselves find ourselves. I have to say that following the discussion that I had with the executive on Friday, I informed the Minister of our decision, our recommendation, and he was very supportive and understood very clearly the situation in which we found ourselves. So that was valuable, really. Are there any questions at the moment to Judith? Paul?
Could I just ask Judith, Judith, is there anything we can do as a board to help and support you or assist you at this very difficult time?
That's very kind of you, Paul. I think just to know you're there in terms of supporting us, but I have noticed one or two of the independent members also supporting in terms of commenting on some of the social media comments as well, which has been very helpful in terms of clarifying some of the misunderstanding amongst our communities about what's happening and why it's happening. But no, other than that, Paul, I'm grateful for just words of support and messages of support that we are receiving, so thank you.
Thank you. Chris?
Thank you, Judith, and thank you for that explanation. Clearly, it's a very concerning time, and I just had a couple of questions really on the implications. You mentioned the staffing issues and the fact that certain staff were shielding. In the first wave, we had vulnerable groups. Have we been able to make progress in protecting those groups?
Are you talking about staff, Chris, or?
Oh.
Yes, I'll bring Geraint in on that, yes.
Geraint?
Yes, thank you, Chris. So yes, we have undertaken risk assessments and where those risk assessments have indicated that people are at risk, at a serious level of risk, we have actually redeployed some of those resources, or we've taken action to mitigate those risks. So as an example, we've had people who are pregnant employees, we've actually redeployed those employees away from the front line into support roles.
Thank you, Geraint.
Okay. I have one other question, if I might, again, relating to staffing and the fact that the system's under pressure. Is that going to have any impact on the proposed vaccination programme?
So one of the things that we made clear in our statement is that we were prioritising specific pieces of work. Clearly, the three areas of work that we need to make sure we're able to continue focusing on is our COVID testing programme, so the Rodney Parade and the team there, making sure that we're able to maintain that, making sure that we're able to fulfil our obligations to the tracing service, or the Grange tracing service, and also then making sure that we are able to support the COVID vaccination programme. So there are pieces of COVID-related work, nothing to do with hospitals, that we need to make sure as a health board we are meeting our obligations to, and at the moment we are making sure that we're able to do that. Clearly, as time goes on, staffing issues may be an issue in those areas. We are recruiting both to the testing centre at Rodney Parade and to the tracing service, and we can update on that later, I'm sure, but also to the vaccination programme. And they are three new areas of work for the health board this year, so recruiting to that has been an important part of our work. But we are going to continue to prioritise that work as best we can, because it is related to our battle against the virus. So, can I ask Rhiannon to come in as well, if possible, please, Anne?
Yes, certainly.
Thank you.
Thanks, Judith. Thanks, Chair. It probably comes in terms of both of your questions, Chris, but just in terms of the vulnerable groups, it's for assurance in terms of those staff. They are being prioritised as well as part of the process for COVID vaccination. So they are being assessed to identify them as priority groups as part of the vaccination programme.
Okay. And I can see that Sarah's got her hand up, Anne, as well, if that's possible.
Sarah?
Thank you. It was on staff wellbeing, Chair. I think in the first wave, although it escalated rapidly, the lockdown measures came in, and we could see that it was going to definitely peak and come down fairly quickly. This time, we know this pressure is with us through till March, in all probability. So, and staff are very tired, and they are also distressed by witnessing serious COVID in large numbers of patients. And so we need to be cognizant as a board that there is a finite number of beds that we can safely open with the staff that we have to enable sustainable staff rotas. And I think that is very different this time to the first time, and in this House board, the staff have been under a lot of pressure for a very long period of time, and so we need to protect our staff in terms of, I think we're already asking the maximum of them.
Thank you, Sarah. That's a very, very well made point. Thank you for that. Tej?
Thank you, Chair. Thank you, Judith, for that rundown. I found it particularly useful to consider the numbers, and that there seems to be almost double the number of non-COVID patients in our hospitals than our COVID positive patients, bearing in mind that some are suspected. I'm just wondering if you could give us, and so that we have a better understanding, maybe the public as well, as to what sort of profile of issues the people that are in our hospitals who are not COVID positive are dealing with. So are we talking about normal winter pressures? Are we talking about severe flu, strokes, that sort of thing. Just a very broad feel for the sorts of things that we're having to admit patients for.
It's all of those things. So no real increase in flu at the moment, but any surgical or medical emergency. So medical emergencies would be strokes, would be chest pain, would be generally unwell people, would be people who've had a fall, would be people with respiratory or chest infections that aren't COVID related anyway. And then clearly surgical patients, people with abdominal pain, all the issues related to surgery that people need operations for, trauma, so serious falls, serious injuries, and clearly cancer patients. So we are continuing to treat suspected or confirmed cancer patients. So yes, it's the usual things that present to any NHS service any year. Without, so far, although it would be a bit early for flu anyway, without any usual winter flu. I can see Sarah's got her hand up, so she's going to do a much better job of providing patient diagnosis than I could ever do.
I thought that was very comprehensive, Judith. The point I was going to add is that COVID is on top of what we normally do. So we're managing 400 plus COVID patients on top of what we normally do. And as I've just said, with a workforce that is finite, so therefore the only way to manage that is to try and reduce some of that normal activity that can wait, which hence the decision on Friday. But then also we've got to look at how we might be able to care for people in alternative ways, and our clinical future strategy is care closer to the home. And so we to be progressing as quickly as possible for all of those service developments that we've been planning, and see how many of those that we can actually introduce quickly in order to manage people in the community rather than bringing them into hospital.
Thank you, Sarah. Emrys?
Thank you for your overview, excuse me, Judith. Recognising the challenges, are there any particular clinical areas at greater risk as a consequence of staff sickness and absence?
My concern is the medical and surgical wards across our services, to be quite honest. I've probably been really in. There are some pockets of medical staffing that are challenging as well, but I'll bring Rhea in on the nursing areas. She might also mention the medical areas, but if not, Sarah can come in on those as well.
Yeah, thanks Judith, thanks Chair. Emrys, we're seeing a different picture to the first wave. So in the first wave we had significant concerns in relation to critical care and ITU. Obviously we surged and we were using multiple staffing groups to support those areas. This time we're seeing, although there is an impact in ITU, it's not as significant as it was in the first phase. But what we are seeing is highly dependent and high acuity patients within our respiratory wards. So we've got very high-end, high-acute respiratory. We have had significant staffing challenges across all areas, but mostly unscheduled care and medicine as opposed to surgery. And clearly within the scheduled care areas, Sarah's been working diligently in terms of staff redeployment across all of the medical fields, but particularly juniors as well. In terms of nursing, though, it is the ward settings, but whilst we tend to focus on the wards, it would be important to note that even the areas of community, so our district nurses are working tirelessly to ensure care provision at home against our care closer to home strategy. And we've had particular challenges within mental health, particularly. Some of that's been associated with the number of outbreaks that we've had within our mental health wards, but additionally that principle of care at home and the challenge for our crisis resolution teams, etc. The staffing depletion is across all areas. And I recognise the position Peter might want to come in terms of allied health professionals as well. But with the mass deployment of staff to cover the mass vaccination programme, flu vaccination, the testing, I would say that we are challenged across all our staffing groups. Thank you.
Peter, do you want to add to that, and then Sarah?
Nothing further to add from me, and just to completely agree with the points that Rhiannon made there. Yep.
Thank you. Sarah?
The serious COVID is predominantly a respiratory disease, so our respiratory staff are particularly under pressure, and we've been thinking through about how to take maximum advantage of their expertise, because what we're finding is that an experienced respiratory consultant can assess a COVID patient much more confidently than a general physician, but we have a limited number of them. So that is we're thinking through how best to use that expertise. But it's also important to say that in older people, COVID very often doesn't present as classic COVID. It presents more, it can present as a worsening of dementia. So I think that's one of the reasons probably why older adult mental health services have found themselves increased acuity of patients and needing to manage outbreaks. And there's also quite a significant percentage of patients who present with gastrointestinal symptoms, so can present to surgery. So I think that's the complexity of COVID. The patients who present with what one might call classic COVID, they go through our COVID pathway, and that's fairly straightforward. But the issue is those patients, of whom there are many, who don't present in that classic way, and that's why we have to be vigilant in all parts of the system. And it's such a highly infectious disease, we have to maintain high vigilance on infection control everywhere all the time, and that is difficult to do.
Yeah.
So I think it's the non-classic COVID that is probably causing us more operational issues than the really classic COVID, although for respiratory teams that burden is significant.
Thank you, Sarah. That was really helpful.
Yeah,
Paul?
Could I ask the impact on primary care services, and also following on from what Sarah said, there has been something in the news about this new strain of COVID and how that may well be factored into the sort of the situation, or the current situation. So two parts really, two questions.
Well, I read a number of GP reports about in the medical literature around last week being the busiest week that people could remember. So I think Nick will pick up on the detail, but the primary care are certainly seeing the lower acuity disease burden of the high levels of incidence of COVID we've got in our community. So they are definitely seeing that. In terms of the new strain, the new strain may or may not be more infectious, but there's no suggestion that it causes a different kind of disease. And they're not absolutely sure it's more infectious. It may just be an association with it started in southeast England, where incidence was on the rise anyway.
Thank you.
Thank you. Nick, do you want to add something?
Yeah, thanks, Chair. Just to reiterate really Sarah's point about the volume of patients with sort of lower acuity presentations with COVID at primary care settings, which we've seen, increase over the last few weeks and months, and the pressures obviously within the primary care system are linked to that, and the normal burden of, winter illnesses and winter presentations, as well as managing the flu vaccination, and now obviously contributing to the mass rollout of the COVID vaccine. I think it's also worth referencing the challenge that a number of practices have because of the size of their buildings and facilities, and how difficult that can be in terms of maintaining social distancing and other, infection control measures, as well as providing an urgent service on the day across, you know, the 80 odd practices that we've got across Gwent. And as Ria's also referenced, the issues with district nursing, community services, and staff availability are, you know, have been expressed, and it is extremely difficult. We should probably also reference that social care have similar staffing issues across both domiciliary care, care homes, and their wider range of community services, where they're seeing similar levels of absence and infection as we are in hospital. And also, as you're probably aware, Paul, we are currently dealing with 53 care home incidents currently across the 102 older adult homes in Gwent, and there are around about 60 incidents in supported living and smaller sort of non-regular closed settings, which are providing huge challenges to all of the workforce in terms of supporting and managing those incidents. You know, a number of GPs have been part of incident management or having to in-reach into homes as they get a significant outbreak and manage the ongoing infection control measures that we're putting in place in all of those homes. So I think the pressure is manifested right across the system, whether it be dom care right the way through to
hospital,
you know, ITU wards.
And I suppose if I can have a follow-up, Anne, is what's, with all that's coming up in the discussion today across all the devolved administrations, what's the key message or messages that we need as a board in the Gwent area? Do we need to get out to local people about the situation in Gwent?
Sarah?
Thank you. Well, the first message is that with the Christmas period coming up, people need to think about staying safe within the rules. So instead of the rules being that's what we'll do and that's the limit that we'll aim for, it's that people need to be thinking, well, that's the maximum, but actually, will I do something safer than that, particularly if they have vulnerable adults in their family and older adults. So it's thinking through individual family plans to keep everybody safe within the rules is the number one message. And then the second part of that is, as we've already said, our hospitals are very much open for those who need hospital care, but we would ask people who aren't sure if they need hospital care or an alternative form of care to phone 111 first and seek advice rather than attending at the emergency department. So we would ask people to attend hospital because they clearly need hospital care, and to seek advice on alternatives if they think that they may be able to receive care elsewhere. Those, I think, would be our two big messages.
Thank you for that.
Thank you. Thank you, Sarah. Are there any further questions to the executives? If not, thank you very much for that very clear explanation. And again, we are very grateful to the huge efforts that are being made by both yourselves and all our staff to maintain our services and the safety of our patients at the moment. If we could move back to the agenda then, please. We have a report on sealed documents and Chair's actions, which is in front of you. Are there any queries or questions on this? If not, can we accept them, please? Yep. My report is very brief. Apart from everything usual, obviously I've attended a large number of meetings with the Minister over the past 3 months, going through the situation as we went through the weeks. Not only about COVID, but about the more routine service provision that we were able to maintain and what our plans were. He is, of course, having to take very difficult decisions, and I found it very helpful to be able to talk to him about the situation in which we find ourselves week on week. there is another meeting this afternoon. We've also had ministerial meetings with our ideas on behalf of the Health Service on the future direction for social care, looking at the excellent work that has been undertaken with our social care colleagues, so particularly over the last 6 months, and how we can consolidate those arrangements and ensure that care is really seamless for individuals. And there is another meeting about that shortly. I've been meeting with local authority leaders regularly to update them on the situation within the health service in Gwent, and they've been extremely positive and supportive in looking at the good work that's come out of our joint working and in offering their collaboration and support with anything that we would wish of them, and that has been really, really encouraging. The Regional Partnership Board has met a couple of times, and they've been discussing the ICF monies, the Integrated Care Fund monies, and the use that's being made of them, because the schemes are now all being evaluated. There is a further meeting in the next couple of weeks about that. Our transformation services and what we've had to step down because of issues of high priority elsewhere, and also the governance of the RPB. And we have had a meeting of the G10, or those are the leaders within Gwent, looking at public service boards and the progress that they're making, and whether or not we can move them onto a more strategic plane. I have, of course, met with independent members on a regular basis, both collectively and individually, and the independent members have received weekly briefings from the executives on COVID. We haven't forgotten all the regional planning work either, and I have been chairing a meeting once or twice in the past 3 months on the vascular centralisation and the way forward for that, and there will be something coming out in the public domain in the next 6 weeks about that. And we have had a meeting of the All Wales Collaborative Health Leadership Forum, which looks at what more we can do to ensure that we get seamless, good accessibility to specialist care within Wales. So it's been very, very busy, but I haven't been anything like as busy as the poor executives, I have to say. Are there any questions? No? Thank you. Resetting governance. Richard?
Yep, this is a paper for our governance structure from the 1st of April. As we've gone through the pandemic, I think there's been some realization that the leaner structure that we put forward has worked. And this paper proposes some changes from the 1st of April to our governance structure. And it's essentially for independent members to accept the changes and any questions around any of the suggestions.
Are there any questions?
Could I come in on a comment, Dan, if that's okay?
Yes.
In relation to the schematic in the appendix, I did wonder whether People and Culture Committee should go on and be shown on that governance arrangement. And clearly, if we decide to suspend that committee at some point in the future, then remove it then, given that this information is in the public domain and people might look to see what committees we run. I think it's really important that it's shown on the schematic, with maybe a little note to say, with a footnote to say that it is under review.
Yes, absolutely. Thank you.
And just to also add, I know Richard said it was for the independent members to agree this, but it's actually, I think he did really mean the board, so that includes the executive.
The board. Absolutely. Absolutely. I have Pippa, Shelley and Chris.
Thank you. I wanted to raise exactly the same point as Judith, in fact, with regard to the People and Culture Committee. And my only other comment really was whether or not we could note But I think this is something perhaps that we should annually review, so that it's set up for an annual review of the performance structure and the actual membership as well. And I didn't see that in the paper. Thank you.
Yeah, no, that is intrinsic in agreeing the paper. We have to review it. Shelley?
And following on from that point with Pippa, it is something that Wales Audit Office have raised a couple of times around effectiveness of committees, which we do need to review. So I think, as you say, that will fall in. I just had 2 points. One was on page 30, where we've got the structural assessment sort of areas for improvement, and there are 3 of those that I think look as if they need further action. I just wanted to be assured about how we were going to address that, so that they're covered within the new governance arrangements in April. So just really, it's a marker more than anything that we pick those things up. And also, in relation to page 32 on the recommendations, certainly I would be very keen to be involved, but I wondered whether or not we could agree that and not only the executive but IMs will provide support and advice to the board secretary along with the executives to inform the accountability review, to ensure that a positive outcome to the new arrangement, so we get all the things in place that we need to go forward in April. So that was an amendment or an addition to the recommendation I was proposing.
On that point, it says quite clearly that the board, and we are the board, will need to assure Welsh Government that the new system will allow the organisation. I do not distinguish between the executives and the independent members on this. We are the board. It will be the whole board. So thank you for the clarification.
Yeah. Sorry, can I follow up on? I think my point was that we're here to support, so if people want us to get involved, if Richard needs sort of us to get involved with our views or, test things out, I certainly would be happy to help him and support in getting this sorted out by April.
Thank you. Thanks very much.
That's very welcome. Thank you.
Chris?
Okay, just an observation really. Thanks, Anne. I certainly support the proposals to streamline the governance arrangements, and as Richard said in his introduction, I think the pandemic has forced us into a new way of working, and the executive have stepped up and got on with doing things. I think it does imply a different way of working, which I think both Shelley and Pippa have alluded to, and I'm just conscious that during what we've said around the COVID means that the executive are quite stretched, but I think for it to be successful, the board needs to find some time to work out exactly how we can make this work as effectively as possible.
Yeah, thank you, Chris. I absolutely agree. Tish, did you have your hand up?
I did have my hand up, but some points have been made by the others. I think it's really just to reiterate that this will be I certainly endorse this, but it will be a work in progress. We are going to have to work differently, so we still have an enormous amount to cover in governance terms with fewer committees, and that is right and proper based on this proposal. But we will have to work through those changes to ensure that we cover everything.
Yeah, absolutely. I would totally agree. Thank you. And we're going to have to learn together about what the framework is to be against which we can judge whether or not this is successful. Is really important for us to work up together. Thank you. Are there any further comments? Or can I have an endorsement for this proposal? Thank you. And we obviously in our briefing meeting will have a further discussion before we get to April, if more than one actually, about how we implement this practically and against what criteria we wish to evaluate it. That's a bit okay. Thank you very much. Okay. Can we move on to section 2, please, and the paper on the Grange University early opening update, Nicola.
Thanks, Chair. And yeah, I'm pleased to report this report to give an update on the opening of the Grange University Hospital in the middle of November, just over 4 weeks ago now. And the information in the report describes how the move itself went, some of the benefits we're already seeing as a result of the hospital being opened, but also a number of the challenges that we have faced and continue to face since we've opened the hospital. I think it probably is worth just pausing at the start to just, emphasise the significance of the task and the undertaking, to open a hospital of this size 4 months early in the middle of a pandemic, which we knew was something that we couldn't underestimate. And we took a very comprehensive risk assessment and a decision as a board to open the hospital early as part of our response to COVID during the winter. And the risks that we felt we would be facing, and I think we absolutely are facing, as we've talked about already today, and the flexibility and the opportunities having this hospital open gives us can't be underestimated. If I just take us through some of the paper, the move itself between the 15th and the 17th of November was successful, I think, as it would ever have been. We moved 111 patients over a 3-day period, starting on the 15th, on the Saturday, on the Sunday, with our most critically ill patients, moving neonatal patients, our critical care, adult patients, cardiology, huge undertaking, working with our colleagues in WAST, followed by a large number of patients on the Monday, day 2, with the final patients contributing on the 17th. We then opened the doors to our main emergency department at 2 a.m. on the 17th of November, with our minor injury units, with our Royal Neville Hall continuing until 6 a.m. that day until they became minor injury units. I can't underestimate the commitment of our staff in getting us moved right across the board, from the clinical teams to the project team. Everybody worked tirelessly over that weekend and the weeks leading up to make sure we could open the doors successfully that week, which we did. So we were really pleased everybody transferred safely and we were able then to open as we set out. I think just picking up the benefits, starting with the 3 key reasons really with which were the main drivers for us opening the hospital early. One of them was the critical care facility and the ability to centralise our critical care resource into a new fit-for-purpose facility with single rooms, and gives us a much better surge plan as our numbers are likely to increase now over the coming months. Notwithstanding the workforce challenges, the environment that we are now working on for our most critically ill is hugely improved and really does give us a different ability to respond over the winter period. The obstetrics, paediatrics and neonatal services, which we know have been extremely fragile for many years, are now in a position of improved workforce sustainability. That's not saying they haven't got risks similar to what we've described, but they are now in a position where the challenges we were facing daily around being able to run 2 services across the 2 sites has now been resolved, and they are in a much better position. And also the provision of a single bedroom environment to help manage COVID. These first 4 weeks are showing the benefits of that with minimal nosocomial spread, and the ability to manage patients quickly in a single room environment gives us much better opportunities to manage the complexities of this infection. And also just the general environment from lots of the feedback from the staff, in working in a new environment has been hugely beneficial. We capture lots of examples of how we've dealt with some of the most critically ill cases. We've had examples of stabilising critically ill children now with a kind of team that has come together from Neville Hall and the Royal Gwent with successful transfer to Cardiff. We've had examples with really fast access to emergency theatres for some real life-threatening cases. We've had a number of cases presented or deteriorated at the Royal Gwent and Neville Hall, and our new step up into site transport service has been really successful and got patients moved quickly. Our first helicopter has landed and safely transferred into the ED. Reported much better increased access for some of our emergency cardiology patients, getting good local services, and the access to diagnostics at the front door. The way it has been designed has been very beneficial as well. So we're trying to make sure we capture all of these examples which are very much underpinning this model in the first place. It's important also just to emphasise the impact that we've had on the local general hospitals as well, around Neville Hall and the Royal Gwent in particular, that I think the week before we moved, one of the A&E consultants described to me as one of the most difficult weeks they faced, as our numbers were starting to increase with limited capacity to manage. And we now have more physical space that allows us the possibility to expand as a result of COVID and the complexity of managing outbreaks and those type of situations. We were, I think at some point this week, we were into 5 additional wards in the Gwent and 2 at Neville Hall, albeit there were lower numbers of patients in some of these wards, but it enables us to manage exposed patients in a much more flexible way, recognising the staffing challenges that brings, but it was a space that we wouldn't have otherwise had. And for recognising the decision we took last week, we had until that point been able to establish more robust green pathways for our elective patients, and we did undertake a large number of elective cases during the last few weeks that we otherwise wouldn't have done. So I think it's just important to capture those benefits in the context of some significant challenges we've also faced. And I don't think we can underestimate some of the difficult days we've had over the last few weeks around settling into the new hospital and managing the demand in the last 2 weeks in particular that is then presenting at the front door. And just to capture some of those, there's no doubt that obviously COVID is the biggest driver of that. Opening a new hospital with a new model of care is a significant challenge on a normal day. We've had to redesign the way the hospital works to make sure we meet the requirements of COVID. We've had to make sure we've got separate entrances for how we manage those with suspected COVID to those who have not got the symptoms. So we've had to split our ED teams into 2 parts of the hospital, and as well as our nursing teams. We've had to make sure that we've got as efficient as possible screening and swabbing and testing processes, which in the context of certain constraints around capacity in those areas has created some delays for us as well. We've also had to reorganise some of our ward areas to make sure that we can do the separation of COVID and non-COVID patients, which has needed some reason. So, and again, I think as we've talked about already, the last few weeks and the demand we've seen on accessing that COVID assessment area has been one of the biggest drivers that has caused the ambulance delays at the front door that we have heard about and that we have been closely monitoring to make sure that we can quickly address some of those issues. The second area that's been particularly challenging is around our step-down process, that we call it. This is based on the model that once people finish their really acute phase of their illness, that they can then be stepped down to the Royal Gwent or Neville Hall or YYF for the continuation of their care if they can't go straight home. So the whole model is based on a very efficient flow of patients through the system. And because of some of the problems around our local general hospitals, around outbreaks, staffing, then our ability to step down quickly has been challenged, as well as embedding these new processes. So again, I know the teams have been working exceptionally hard every day to make sure that we put our efforts in the right part of the system to make sure the step down process can efficiently be implemented. We've had quite a lot of work going on around making sure that we've got the appropriate presentation across the system. We have got, and we're monitoring this closely, but there are numerous examples where people are presenting to the Grange that could be managed at the ELGHs. And similarly, some people are presented to the local general hospitals that need to be at the Grange. So whilst we've got an intersite transport service that particularly sought step-up patients, trying to get people to use our local general hospitals, our minor injury units, our urgent care centre, which I know Nick will pick up later, is hugely important. And we've been putting additional staff into our flow centre. We've been working with 111 to make sure that our algorithms are consistently being reviewed and adjusted to reflect the way patients are presenting at our hospital. So this is an ongoing piece of work, despite doing significant amounts of communication with our communities, both through social media, the leaflet drops, schools. I think this is a natural phase of our new kind of system of care until it's beds down. But anything we can do to continually try to, we also try to encourage people to ring 111, and I know Nick will pick up phone first as well, so we can start directing patients much more than allowing them to make their own decisions, which is very difficult for people in an emergency to try to make the right call of where to go. It's also worth noting, there's a number of support services and patient experience issues that we've picked up, and we've tried to act really quickly on any issues that have come up in terms of feedback to make sure that we respond, whether that's to do with our reception services, contact in the hospital, catering services, access to Wi-Fi. All of these early issues we have made sure that we've responded to very quickly and will continue to do so. So that's just a bit of a summary of the benefits and the challenges we've had in the last 4 weeks since the hospital's opened. There is a number of different systems and things we've put in place where we've got daily clinical huddles, really trying to make sure the teams are coming together at the Grange so that we are working together to make sure that this new hospital and the new system works effectively. And we've also got a continued improvement programme looking around emergency department processing, how can we use technology better around using our care flow that we are trying to implement. We've got Lightfoot in even system-wide intelligence that we're reviewing on a daily basis to give us good intelligence into how the system is working. And we'll be continuing to build on these to continuously review and adjust the way the hospital works. But, whilst we're dealing with COVID, we know that this hospital is not going to work in the way completely that we intended it to whilst we deal with these challenges. So I leave it there, Chair, and happy to take questions.
Thank you very much, Nicola. And can I thank you and your teams, the Clinical Futures team, for the incredible amount of work that you undertook to get this hospital ready and to get the staff in and familiarised with their new areas and the enormous effort that took to be able to move and to be able to use this new facility. For goodness knows what we would be doing if we did not have that as part of our planning. It would be difficult to imagine us managing it all. I think that Paul wishes to say something.
Yeah, could I just add my thanks to Nicola and the team as well for the superb work that's been undertaken, particularly those involved in the clinical support staff and in particular the communications team, who did a brilliant job in trying to gel all this together and particularly working with the Community Health Council and getting the feedback from the community on what's been required. The question I wanted to was about recruitment levels at senior level and in particular consultant levels and how we're doing in terms of recruitment at that level as well as recruitment generally, because with a new hospital and there's new facilities, sometimes that has an added attraction. And I just wondered where we are and where we're likely to be on recruitment of consultants and staff at senior level and nurses generally.
Okay, thanks. Geraint, do you want to pick up that?
Yes, if I can, Nick. Yeah, thank you, Paul. So I think in terms of our plan, we had 2 phases to our plan, phase 1 and phase 2, and both were successful. We've largely recruited all the staff that we planned to recruit. However, there are some gaps that, as we anticipated at consultant level, because there are national shortages. So, for example, acute care physician and geriatricians, there's 2 examples where we've struggled to recruit at that consultant level, but we're looking at plans to put plans in place to actually try and mitigate some of those recruitment problems. And again, in terms of nursing staff, we've recruited largely the numbers that we needed, but of course we have an significant underlying deficit across the health board in terms of nursing vacancies. So that will play into the overall position across all of our sites, not just the Grange hospital. So I think overall, Paul, we've done really well. And the point that you made about the facility being an attraction. I think that has certainly materialised. You know, we've been able to attract most of the staff that we needed, and I think in part that's due to, you know, an exciting new facility.
Thank you, Geraint. Phil?
Yeah, thank you, Anne. Thank you, Nicola. Great report, and I mean it's a brilliant experience all round. I think to see where we are and where we've been. And I just wonder, one of our major challenges prior to opening the new hospital was our paediatric services, and I just wonder how the teams have managed to bed in together in one unit, and whether the new hospital has actually managed to alleviate some of the concerns that we've had certainly over recent months.
Yeah, thanks, Phil. And Sarah may want to come in. She may have been speaking to them more frequently than I. I know from in the first week when I was speaking to them, they were very settled and very pleased with the way the move has gone, and were, you know, thrilled to be in together, really. So I haven't picked up any issues at all around the team working. It seems to be bedded in really well. One of the highlights probably for me was on that weekend, you know, seeing the neonatal department come together in that unit, who were absolutely thrilled to be in the new environment with parent facilities that, you know, was just completely different to what they'd had before as well. So, you know, seeing those teams to come together that weekend, you know, despite the challenges of moving in the hospital and how busy it is and teething problems, you know, they were absolutely thrilled, and I picked up no concerns around how the team have been working together. But Sarah may want to add to that.
Well, can we bring in Ree first, please?
Yeah, thank you, Chair. Thanks, Judith. Really positive feedback from staff across all of the areas: paediatrics, midwifery, maternity, and obstetrics. It is a truly tremendous environment for that specialty. I probably just wanted to add that we've had probably the most positive feedback in that specialty from the public and patients attending. Daily feedback in terms of the positive experience. The main area where there's been concern, where we have had some more negative feedback, is in relation to visiting, and that's not a local decision, but there are areas where we've taken immediate action to resolve those issues. So really positive for that specialty, thankfully.
Thank you. Have you anything to add, Sarah?
Only that I did write to thank the two clinical directors because I think the board really understood the leadership that those two doctors provided to maintain safe services for the last 2 or 3 years. And so I think just to share with board members, I did write on our behalf to say thank you. And I think, Phil, it's just an overwhelming sense of relief to have made it into the building and to be together and in that wonderful facility, and to feel in a much more concrete position in terms of being able to maintain staffing levels and as Rhiannon has just said, you know, great feedback from patients. And it is important with all of the pressures from the COVID pandemic that we as a board, we keep sight of that whole system of healthcare that we are responsible for providing, and all of the risks of the pandemic, and one of them being that people who need access to urgent care for other reasons can't access it. And maternity is one of those absolutely essential services, as are services for sick children, and the move into the Grange undoubtedly has made those services safer. But we've also been able to open up our 2 cardiology labs. You know, there have been a number of things that we've been able to do and protect because we moved into the Grange that was so much more difficult in the first wave, notwithstanding the difficulty of managing and providing good care for our COVID patients.
Thank you, Sarah. That's a point really well made. Thank you. I have Pippa Emrys Teague.
Thank you. Thanks, Anne. Yes, thank you very much for that, Sarah. That was it wasn't part of the question I was going to ask, but it's really good to hear that. And I'm probably going to add my congratulations, just like everybody else would, on actually getting the hospital open. I can't believe in the middle of a pandemic how much work has gone in, and how you know, there's always going to be a few teething problems, and we know that, but it is an amazing job that it's happened. I think the only challenge really from the public's perception is where do they go for you know, if they've got a problem. And I have picked up some of the, I am picking some of this up outside of the meeting, but there is something around the public perception of what's a minor injury and what's an emergency, and what do they do if they think they have a major injury that isn't an emergency. So I had somebody who contacted me recently about a child who'd fallen and they thought they'd broken their arm, and they weren't certain whether that was minor or where they should go for that. And they did know to call 111, which is what they did. But I think there's probably something about our public messaging in how we can get people to understand what a minor injuries unit can deal with. And although we've given that message in our leaflet, I think that's an area we could reiterate in order to stop people presenting at the wrong place. So but again, thank you so much for getting this hospital up and running, because if you hadn't, I'm not certain where we'd be right at the moment.
Sarah, did you want to add something?
Thank you, Pippa. I think you answered it perfectly yourself, really, which is that we've described as clearly as we can what a minor injury unit definitely can do, but there will always be, and broken bones are a very good example, you know, and of which is it a minor injury or is it not, and therefore our very clear message is to phone 111 or go to the 111 website, probably with a broken limb, phone 111, and you know, they rather than because when we were talking about the communications, we couldn't give the public a if this, do that, a sort of long, exhaustive list. That's actually what 111 is there for. You know, they've got that decision-making algorithm in front of them that has been carefully thought through and is clear in terms of risk, and will always direct people towards an ED if in doubt. So I think our clear message is, if in doubt, phone 111 or the website.
Yeah. Thanks for that. Emrys?
Yeah, just to say, Chair, just to say thank you to Nicola for an excellent overview, and just to echo colleagues' comments. This has been quite an achievement for the team, and saying just very well done for that. My question is around the step-down process, is that patients have to stay I assume patients are having to stay longer in hospital, and this will have implications on the capacity of our hospitals. Are the length of stay significantly longer than usual, and when might they improve?
Thanks, Emrys. I haven't got the exact numbers in front of me, but I'll get them sent to you. But we've been monitoring through the Lightfoot kind of system that we've got what the length of stay is each day compared to what we expected the length of stay to be. And it was interesting, in the early few weeks, we were seeing lengths of stay of averaging around 3 days, which is what we'd expected for our patients in the Grange, recognising there's variation around that. And we have seen a slight increase in that by a day or so in the last week or two, where we've had that extra demand and we've struggled to get the step down because of the pressures on the local general hospitals. But we are monitoring that carefully. But it's not hugely adrift from what we would expect, recognising there is further improvement that we can do based on what we're learning already. But we are, and I know Sarah's a key advocate of this, getting people straight home where we can from the Grange is absolutely the first attempt, and then stepping them down to a local general hospital or a community hospital if that is the most appropriate place for them to be. But we really are trying to embed that model and that culture very early on to step people down or step people home as soon as they are ready. So overall, early signs are, the model is kind of working, but we know that there's a lot more improvement we can do around that as we bed in. Sarah, did you want to add to that? I can see your hands up.
I think it's the implementation of a model which is a specialist critical care centre supported by local general hospitals that our consultant colleagues in particular have got to familiarise themselves with, in terms of what as Nicola has said, the reason for stepping down from the Grange to a local general hospital needs to be very clear why somebody needs to stay in hospital and what they're stepping down for. So that's the focus of attention at the moment, that improving on that handover, so that we're absolutely clear why somebody is stepping down and they can't just go home. And it links to my earlier point about, could that care be provided in the community, particularly at the moment when the safest place for someone is their own home in terms of infection control. And so if we can provide that care in the community, then that's got to be the first thought. And then if somebody does need to step down, we're clear what they're stepping down for and when that might end, and what the discharge plan is at that point.
Okay,
Thank you.
you.
Thank you. Steve?
Thank you, Chair. If I can just take us back to the conversation about people presenting to the right place at the right time. And I agree very much with Pippa's comments about there being some confusion, a small amount of confusion, despite the mammoth work that the comms team have put in. Can I just ask where there have been, Nick, you did mention that there will have been some people who have presented to the ELGHs when maybe they might have presented to the Grange as a more appropriate choice. Have there been any patient safety concerns, or have we been able to convey people from those ELGHs to the Grange or to the most appropriate place for their care?
Yeah, thanks, Tej. The commissioning of the intersite transport service, we commissioned capacity to deal with around 30 plus step-ups every day. We hope we would not be in a position where we were stepping up that many, but we recognised in the early months of a new system we needed, and there was a particular concern for clinicians of patients wrongly presenting at the ELGHs. So we put in what we considered as an overcapacity for step-ups. I've seen some data which is at least about half of that we've been stepping up, and generally has been working very well. There are set kind of criteria and time scales which will be managed through the flow centre. There has been one or two, I think, two examples where this has been longer than one would expect, and they've been investigated as an individual cases. But on the whole, the step-up process seems to be working well.
Thank you.
Could I just make another point, please? Thank you, Chair. In terms again of comms, people do understand different messages different people will understand a single message in different ways. And as I said, all credit to the comms team for the immense amount of work that they've done. I think this is something that will bed in over time, and I think the integrated wellbeing networks that we have active in our communities will be an incredibly useful resource in getting out those messages to our communities in a way that they understand and they can relate to. So I think that infrastructure will certainly help, and it will just take time.
Yeah, I think absolutely. And we've just got to keep reinforcing the message all the time, and to give assurance to people that they will get to the right. Try and use the alternatives in the first instance. Phil, have you got your hand up? No? Are there any further questions to Nicola? Thank you very much indeed, Nicola, for all that hard work and for successfully commissioning a major new hospital expeditiously and without fuss. Thank you. Can we move on, please, to the COVID vaccination programme?
Thank you, Chair. So this paper summarises the comprehensive planning that has happened over recent months in anticipation of a safe and effective vaccine being approved by the medicines regulator. And that approval has now been given for the Pfizer vaccine, and so we started vaccinating last Tuesday, and we are following the Joint Committee on Vaccination and Immunisation prioritisation, which starts with staff who work in care homes and residents of care homes, and then is frontline health and social care workers, and those over 80 are the second priority group. So that we're starting with the top priority group, and we have been doing some of our frontline staff as well. The vaccine is logistically problematic in terms of it's both storage and then reconstitution is also quite technically difficult as well. So the programme is being delivered currently from the mass vaccination centre in Cwmbran. We anticipate and hope that the Oxford vaccine will achieve approval by the regulator, but of course we don't know that for certain, because the regulator will only give that approval if they're confident it's safe. But that vaccine is stored in a fridge and is actually technically easier to give as well, and that will enable the programme to reach out into communities more rather than people having to come to it. So I can take questions if members of the board have questions at that point.
Thank you, Sarah. Tish?
Thank you, Chair. In terms of vaccinating our staff, Rhiannon, I know you referred to this earlier on in terms of prioritisation. I just wondering if you could just take us through that and how it's working. It's partly to endorse the work that we did at a very early stage as a health board in carrying out risk assessments for our staff and identifying that need and implementing or putting in place a framework. So I'd really like to know how it is that we are prioritising staff for vaccination, particularly frontline staff and those that have been deemed at maybe a higher risk. Okay, so the prioritisation, the JCVI guidance is essentially answers three questions. So the risk of an individual being exposed, the risk of that individual becoming seriously unwell if they do become infected with COVID, and the risk of that individual passing the infection to vulnerable people. So it's balancing those three things in coming up with that categorisation. So our frontline staff are at higher risk of being exposed, and as you rightly say, Tish, their individual risk is calculated by our risk calculator. So what we have done is we have asked the divisions to identify the staff who are most at risk of being exposed and to forward that list of staff who the vaccine programme will then slot into and offer appointments to. Because at the moment the vaccine is in relatively short supply, so the numbers we can vaccinate are not yet that high. And the planning, the time between knowing how much vaccine we're getting in 1 week and therefore allocating slots
is a very fast turnaround. So for this week, we are working with those at highest risk of exposed, but then being exposed, but then we are moving on to risk of exposure and risk to the individual based on the risk calculator on ESR. So we'll be taking account of both.
Okay. Are there any further questions to Sarah? Shelley?
Yes, Sarah, I think we've partly covered it in terms of the vaccination programme. I just wanted to just ask, generally, is this brilliant that we've got it up and running and it seems to be working? And I know the feedback I've seen on in the press and social media has been very good. Just wondered, sort of the vaccines we've got at the moment, are we seeing any no-shows? And have we, because I know I've read again in other places where they have some of the vaccines, I think it's 3 days or something, and it has to be used or whatever. So are we having any problems like that? And also how confident we are about that forward, the amount of vaccine we're going to be getting over the next couple of weeks. And I know it's a bit, at the moment, you're not able, but, are you fairly confident that we'll get what we need over the coming months? Obviously, with the Oxford vaccine, when it comes in, that would help as well. I appreciate that. But because I think it's an expectation which people have to have at the moment about how quickly they're going to get vaccinated. But I think it's important, people are realistic as well about it, so that we don't get what you were talking about earlier, Sarah, about people stretching rules and that sort of thing, because the vaccine is round the corner.
Yeah, so on the current stage of the programme, staff are volunteering for the vaccine.
Yeah, okay.
So they are people who've put their name forward wanting the vaccine, and we are needing to manage expectations amongst staff in terms of who's going to get their vaccine when. So the really positive news is that the pressure is on people wanting their vaccine now rather than people not wanting the vaccine.
Yeah.
And I think there's two parts to that. In health and social care staff, as I said earlier, have seen COVID. They know what a serious disease it is. And as I've said in answer to the question in previous board meetings, each individual needs to make a decision about balance of risk of the disease and balance of perceived risk of the vaccine. And clearly, NHS staff are absolutely voting with their feet in terms of that balance of risk being greatly in favour of the vaccine. And that is good for our staff that we are able to offer it to them. But hopefully it's a very strong public message as well, that the staff who most understand the risk of the disease and the risk of the vaccine are all turning up willingly and wanting the vaccine. And then in terms of the future supply, I think the answer is that we get given what the supply is at any one time. Currently only the Pfizer vaccine is approved, so that's the supply that we've got, and that is in relatively small numbers at the moment, but we expect it to increase. Other vaccines being approved, and it's Oxford or others, then you're bringing in new supply, because those manufacturers have got their supply organised and will start producing vaccines. So the more that are approved, the more vaccine we will have. We will have a limiting factor in terms of workforce, because there are only so many people we can vaccinate with the workforce we've got. But again, it's how you can be as efficient as possible with your clinical workforce, your registered workforce, by people working under supervision. So all of those things have been planned through. But your fundamental point about people thinking they can take risk because the vaccine is imminent, in the interviews I've done this week, I think the message is the absolute opposite, which is the vaccine is so close, don't take any risks. It's not, we're no longer in the situation where this could go on for a very long time. we're now in a situation where we can be fairly certain that come next summer, the levels of serious illness that we're currently seeing will be greatly reduced because we know the vaccine is effective in preventing serious illness. So the very clear message is don't take any risks now because having the vaccine is so close.
Thank you.
Thank
Rhys,
you. Thank you.
want to add to that?
Yeah, just to add to what Sarah said and to pick up on one of the IM questions in relation to use of the vaccine and no waste. This is obviously a very precious vaccine. Our approach is one of no waste, and when people are scheduling for an appointment for their vaccine, they're indicating if they could come at short notice. So if there's any indication that vaccine that has been made up, constituted, is available, and slots, the patients that will, or individuals have attended, then people are being contacted at last minute, even out of hours, to have the vaccine, and that's happened minimal occasions, but we have not had waste.
Sarah?
And I would just add to that that any vaccine that really is within less than an hour of being wasted, we are immunising the vaccination programme staff because they come under that heading of at high risk of exposure because of the sheer volume of people who are coming through for vaccination. So I was told by Dr. Liam Taylor this morning that we absolutely are not wasting any of it.
Thank you. Pippa?
Yes, I just have a question really. It's probably something about process, but does the vaccine go through the kind of normal pharmacy system? And if so, does that place extra pressure on pharmacy, or is there a different process for it? I was just concerned about the pressure on pharmacy, I guess.
It's a very good question, Pippa. So the process is supervised by pharmacy, but carried out by nursing staff. So we agreed a protocol that pharmacy proposed and have signed off. But it's actually very time heavy for registered staff because of the way that the vaccine needs to be reconstituted. So it isn't heavy on pharmacy time, but it is heavy on nursing time. I don't know whether Rhys wants to add to that, but that would be my summary.
Yeah, thanks, Sarah. I mean, it has been intensive for pharmacy colleagues because of that supervisory role. I think particularly as we were about to launch as well, the significant input, particularly over the weekend before the commencement, for pharmacy colleagues and other registrants. There were 5 changes to the standard operating procedure on the Sunday beforehand. It's just a phenomenal amount of work for everybody. And I think, as Sarah's mentioned, it's going forward as there's more vaccine available. Our risk is about the number of vaccinators that we'll have, but we're working through that with workforce colleagues.
Thank you. Any further comments or questions?
Yes, please. It's excellent news about the vaccines, and I think we need to do all we can to promote this message within the community. Just to ask about the current vaccine, because the temperature level I understand that you have to keep it at is considerably, I think is it -40 or something, and whether any implications to that, and of course it's 2 doses as well. I think it's the same with the other vaccines coming in, and I just wondered, are there any implications to that with regard to our -70 with regards to our area, for example, and that temperature level?
So it's distributed in a highly temperature controlled storage system. The issue is once you open it, you've got a limited period of time to use it. So there are time limits all the way along the distribution chain. So from when it leaves the distribution centre where it's being stored at -70, the clock is ticking all the way along, and then once you open it, that clock ticks very fast indeed. So it's about making sure that you have that's why the planning of the slots and making sure you've got people in them and ready to come at short notice is so important, because once it's opened, the vaccine isn't viable for very long. The vaccines that we hope will become available that can be stored at fridge level temperatures then are like, for example, the flu vaccine. And the cold chain, it's technically called the cold chain, Paul, and the cold chain becomes so much easier to manage, because it would be like other immunizations that we're used to managing, and you can put that in a cool box and take it to care homes or schools or wherever much more easily. So this particular vaccine, it's clearly extremely welcome that it became available so quickly, but from a logistics point of view, it's not easy.
Thank you. Can I ask about prioritised groups? Are the prioritised groups of the vaccine the same in England and in Wales, or are there any differences to priorities in terms of who gets the vaccine first, in which order?
So the Joint Committee on Vaccination and Immunisation is a UK professional advisory committee that advises all 4 governments, and all 4 nations are following the advice of that committee.
Thank you. Thank you very much. Any further comments or questions? Thank you. A good start has been made, and we want to see it escalated, obviously. Could we move on to the Q3, Q4 plan? Now, this report is here for confirmation. As you will recall, some time ago, the executives had 2 weeks to complete this comprehensive piece of work, which they did indeed. But unfortunately, obviously, the Health Board was not in a position to endorse it, as we were not meeting formally before it was due to be submitted. So it's in that context that we receive this report. Additionally, obviously, the recent situation has altered our ability to manage the Q3, 4 plans as we indicate within this paper, and we will be picking that up later during the meeting. But Nicola, if you'd like to just briefly outline the issues.
Yeah, thanks, Jane. Thanks for setting that context. It is worth just re-emphasising that the IMT process was paused, and we went into quarterly planning cycles, and therefore we'd done the Q1, 2. This was the Q3, 4 that was put together as part of our response to winter. It formed part of a series of plans that underpinned Welsh Government's winter protection plan. That was alongside local prevention response plans by the local regions, as well as RPB plans and so on. So this was very much the health services plan. And as you can see, just going through the contents page, you know, it covers the broad range of our responsibilities over the second half of the year, ranging from how we are managing COVID, how we are dealing with things such as the TTP vaccination, testing, running essential services, both across primary and secondary care, which we were talking about earlier, how we are planning to prepare for winter, and that covered very much things such as flu vaccinations, opening the Grange early, which we've just talked about, and making sure that we had surge capacity in place to respond to changing demand of the pandemic. It also looked at how we could possibly restart some of our routine services at that point in time, and also covers things such as digital, a big focus on our workforce, both in terms of the staffing requirements and well-being, and finance in terms of you know, trying to come up with a financial forecast in the context of a lot of uncertainty. So, recognising we're 2 months into the plan, much of the areas set out are progressing in line with our expectations. There's probably a few areas that have thrown us off course now, as you can imagine. So when we go back into the plan, our most likely scenario at that point was based on the Swansea model that we were using back in September, which we expected a peak of about 250 COVID patients in January. As Judith set out earlier in the meeting, we're on over 430 plus recovering patients plus suspected. So we've got a much higher level of COVID in our hospitals this month than what we predicted at that point in time. And we know that the latest modelling that was submitted last week by Welsh Government at an All Wales level shows that we've got a further peak to expect in January, as Sarah set out as well earlier, so with a difficult few months ahead above what we predicted in that plan. Whilst we, as we've said, we still see in high levels of non-COVID, which during the first wave we saw a drastic reduction in non-COVID, which helped us manage. Our non-COVID levels are not as high as we'd possibly predicted they could have been in this plan, thankfully. I think the complexities of managing the different pathways of COVID are understood better now in terms of, and the plans we've developed in terms of managing the definite, probable, possible, and those green pathways add new complexity to our capacity, which wasn't probably factored in at that point. And I don't think we expected the workforce challenge to be as significant as we are currently seeing. And again, that comes with the incidence of COVID in the community and the sickness levels, the impact of isolation, and so on. So our workforce challenges, I would say, are at a more unprecedented level than what the plan expected. And as we know, last week we have cancelled a number of routine services that we had managed to restart. So I think the last 2 months, that's where we've seen a significant change, particularly in the last few weeks. And we are now in the process of refreshing our updated surge plans in the context of the recent modelling that came up last week as to how we will be able to respond to the demand that we anticipated heading our way in the next 3 months. With the capacity we've got, physical capacity is less of a constraint because the Gwent and Neville Hall does now have space we can use, but workforce is without a doubt our biggest constraint, and our surge plans will need to be reviewed and refreshed based on the workforce we know that we will have access to. So that's kind of where our urgent attention is this week in terms of refreshing this plan. Thanks, Chair.
Thank you, Nicola. Any questions to Nicola? Chris?
Thank you, Nicola. And obviously, a tremendous amount of work's been done. I had a couple of points, and outpatients was mentioned earlier as one of the things that we've had to curtail because of the surge in cases. But the plan is very positive about the use of virtual outpatients, and I just wondered, notwithstanding the difficulties we're facing at this particular moment, are there opportunities for increasing the virtual outpatient activity over the next few months? And secondly, my second question's around staff wellbeing and the very extensive work that's been done there. And it was good to see that the Health Board's seeking to be a leader in staff wellbeing across the issues raised from the pandemic. And I just wondered how far off we were in terms of being that leader in delivering staff wellbeing support to our staff.
Glyn, if we can deal with the virtual issue.
Yeah. Okay. Thanks very much, Chair. Yeah. No, it's actually quite a timely question because some data was recently published on virtual consultations that have taken place during this year across the whole of NHS Wales, I think we were in a good position in terms of investing in the technology early on and getting ourselves prepared early on during the pandemic. So up to the end of September, just to give you an idea, up to the end of September, across the whole of Wales, there were over 54,000 video consultations undertaken. Now, some of these include consultations in general practice as well. So out of that 54,000, over 19,000 of them were undertaken in this Health Board area. So that's over a third of all the video consultations that were undertaken across NHS Wales. So I think it probably demonstrates the great progress that we've been able to make during the first 6 months of this year. Obviously, in terms of continuing that, we aim to do that and sustain it. And clearly, the suspension of some of our outpatient clinics at the moment was to enable us to better use some of our capacity and workforce in the short term. But we would expect to not only, I think, maintain our use of video consultations, but where possible, increase that, and clearly it's important that we do it in the right
Evidence-based trauma pathway in urgent care. We've got a mindfulness cognitive therapy program, an integrated peer support network pilot with a number of the medical royal colleges, and also we're pursuing with Welsh Government the setting up of a centre of excellence at the Grange Hospital, University Hospital, which will be about clinical research, innovation and consultancy. So I think that indicates that in terms of our approach and our strategy, we've got some very important components to that, alongside all of the other work that we're doing on a day-to-day basis on the ground in terms of supporting staff. So as an example, our facilities team at the moment are requiring quite a bit of support, and we've got a support program in there specifically helping them. We're also going to have some safe space conversations with senior medical leaders who require that sort of facility, given all the stresses and strains that they've been through in recent months. So I think, Chris, we are actually already leading the way in Wales on that.
Thank you, Geraint. I think that's very impressive, and we have been kept up to date on this really important subject of the maintenance of our staff and the services to them. Is anybody else any comments? No? Can we move on? Thank you very much, Nicola. We understand the circumstances, and we'll pick up some issues in your mid-year review of IMTP priorities. Might we move to the primary care states strategy, please, Nick?
Yeah, thanks, Chair. So colleagues will probably recall that at the last Planning and Strategic Change Committee, we brought a sort of outline of where we'd got to with developing a primary care and community service division strategy for estates. So the full document is included within the board papers today, which I'm seeking approval for that strategy as we move forward. And then you've got an executive summary document, which I think we shared some of at the Planning and Strategic Change Committee. And basically this strategy lays out our estates approach to the delivery of our service strategy. And I think it's incredibly important that we have an estates plan that is linked to the delivery of the two key tenets of our service strategy, that we are looking to deliver place-based care with multi-services, agency services clustered around a community or a neighbourhood, and that this focuses on us providing care closer to people's home. The strategy itself provides an overview of both the national and local strategic contexts, and includes references to the Wellbeing and Future Generations Act, Healthier Wales, and the Primary Care Model for Wales, and the Health Board's Clinical Future Strategy. And I think it is a key part of how we now take forward clinical futures now the Grange is open. In terms of the document itself, it outlines our vision really to ensure the long-term sustainability of primary care services throughout Gwent, and establishes a programme which should deliver a greater resilience for our teams, but also very much emphasises the need to bring together teams of health, social care and third sector staff around a structured coterminous approach, and that they would work together in a local area through a network of health and wellbeing centres, which we would establish across Gwent, that would then be supported by a multidisciplinary workforce. The overall vision for the strategy is very much an enablement of a hub and spoke model, so we can incorporate the long-term sustainability of some of our GP practices, improve and build upon what we've already delivered with regards to the health and wellbeing centres, and colleagues will be aware of the approval of the final business case for Tredegar and the establishment of a health and wellbeing centre there, and that the outline business case for the Ringland Health and Wellbeing Centre is now progressing. We've looked right across Gwent with our teams to develop that network, and it's very much established within our NCN network as well, so that we're clear where those places are that we would look to and seek to deliver a health and wellbeing hub. We then look to support those with enhanced care hubs in regional locations, and this is really the next step in redefining what we mean by community services in response to the right sizing community service work that was done by Welsh Government this year. And those enhanced care hubs would basically be in regional locations, most likely in our current community hospital locations, and they would fully enable that whole model of care closer to people's home and the delivery of services that would support people to remain either in their homes or very much supported in their community. So I'm not proposing, Anne, to go through the whole document, but because obviously we've highlighted previously our approach, I think it's just important to probably stress that we've got some agreed strategic objectives which have been shared and worked through with all of the NCN networks, that this strategy recognises the need to retain the current provision of GMS through general practice surgeries, but is supportive in terms of providing those hubs for the GPs to operate around and as spokes, and that RITS really does take us beyond a short-term approach into a much more medium and long-term development of our network of primary care as we move forward. It's a well-advanced sort of strategy. There's still work to do, and later on in the document you see some of the local areas where we've already got places for virtual hubs or physical hubs established, but also where we prioritise development as we move forward, in particular in some of our more deprived communities around Caerphilly and Blaenau Gwent, where there's significant development either planned or in place. I think the next step would be that we're going to share this approach with Welsh Government to seek to access funding through capital and their pipeline function. And my understanding is that we're well advanced in that, and in comparison to other health board areas who've yet to really complete this piece of work, that we've done a 6-facet survey, we're clear where we've got buildings that we need to dispose of, and also buildings that we can enhance and build upon to generate that network of spaces. So happy to take questions, but it is here for approval today, Chair, and hopefully we can then continue to develop the local plans on a regional basis.
Thank you, Nick, and thank you for a really well constructed report. And I was really pleased to see the service strategy and the estate strategy so linked together. So it'd be clear on what basis we would be evaluating this for the future. So thank you very much for that. I have a couple of questions, Phil and Tej.
Yeah, thank you, Anne. Great to see this strategy, Nick. I think it's moved on an awful long way, actually. It's great to see it in one document. It's quite innovative on the one hand, but on the other, it actually talks about in a very clear way things that we've thought about and tried to plan and deliver over quite a long period of time. So I think it's great to see it and very welcome. My only concern about it, if it is a concern, is that it could be seen as a health board document and strategy, when actually the success of this depends on other organisations outside the health service. And I just wonder about how embedded our partners are really in this strategy, because without them actually seeing this as being one of the fundamentals on which they plan their community services, then we have little chance of it actually succeeding and delivering the outcomes that we all want. So I just wonder really how you think that have you thought about how we can really ensure that particularly our council partners, for example, really embed this in their thinking and their plans going forward, because this really is a community strategy, really. I know it's headed as a primary care strategy, which it clearly is, but it's a strategy for how we provide our community services. It might not give us the benefit of it, unless our partners are absolutely, totally signed. And I wonder, for example, whether this needs to go to, it may need to go to G10 and the like. It obviously needs to go to Regional Partnership Board, as it will anyway. But I think we need to think about really how can we make this not just a strategy for the health board. I know we're thinking about that anyway, but I'm just raising it as a concern that I have.
I think it's a very valid point, Phil, and I think we've got examples where we've got really good engagement, and it is very much a joined up approach. So if you look at some of the work that's been done around Monmouthshire and the integrated team that operate out of Chepstow, which is very much part of that enhanced care hub, it works well. But then I think, on the other hand, we've had real challenges incorporating that integrated approach at Ringland in Newport with colleagues there. So what we did on the back of that was we've used the process of engagement through the integrated wellbeing partnership boards, which have local authority members sat around the table to sign off each of the individual regional plans. Now, the proof of the pudding with all of these things, Phil, of course, is in the action and the eating of it, in terms of whether, once we get to the point where we start to develop a business case for a health and wellbeing centre, whether they are fully engaged. So I think taking up the route through the RPB and a further sharing on a local level with individual councils will be really important as we try and move this forward. And yes, trying to develop it more as a community service strategy, now we've got that estates piece sorted out, I think it would be really important.
Judith, do you want to add something?
Yes, please, thank you. I know Phil's question was about the joined up delivery of services to communities and the need to work with partners, but just coming at it as well from a strategic estates perspective, the G10 meeting last week agreed that it wanted to do some positive collaborative work around public sector estates across Gwent in terms of how we're using it. Is it in the right place? What potential is there to join up some of our estate strategies? And so I made reference to this strategy coming to the board today, and clearly the broader estate strategy that we have as a health board, which will really now give us the platform to have those conversations with our other public service partners about location. So I know Phil's comment was about how we work together to deliver the service, but actually we can work together to deliver the buildings as well sometimes. So just wanted to flag that as part of this work.
Thank you, Judith. Tish, and then Chris, and then Shelley.
Thank you, Chair. Really, to endorse this piece of work, it's great to see that that the estate strategy is dovetailing with the other work that is going on, and I can just reflect to you my experience of working within the advice sector, the third sector, and supporting the third sector in desperately wanting to work within primary care and frankly just not having anywhere to sit in surgeries or near surgeries or working in any place that would work in partnership with health services. So I think this would be very welcome to the third sector who want to work with those health services. Just a question. The paper does set out very well the benefits in the whole. I'm just wondering, where we have these integrated services already set up, what is the feedback from our GP colleagues around the support that they get, both for their patients, but also for them as practices? Because we know that sustainability of GP practices has been a problem, and that many feel unsupported. I'm just wondering what the benefits are. I know what the benefits are, or I have heard. It's just for the benefit of colleagues and the public.
Okay, Tish. So I think, it's difficult, isn't it, to have empirical evidence about whether or not an MDT provides, further resilience to a GP practice and that evidence to support rolling out the model. I can only really go on the the evidence of support that we see from a number of practices in NCN Leeds and others around how we deploy some of the resource. So they've committed their own NCN budgets in the past to the delivery of practice-based pharmacy, which obviously provides quite significant resource in terms of additional appointments and the benefits that that brings to patients and also GPs in not having to conduct medicine reviews or simple script changes. And I think that's, you know, they continue to invest in that model and continue to seek to enhance it right across the, you know, the NCNs that we've got. And linked to that, if you look at the new work that we're doing around the psychological wellbeing practitioners, where we're now looking to deploy these across 15 different practices between now and Christmas, well, now and the beginning of January, if I'm honest, that every single practice is supportive of that approach and recognises the benefit that that gives them in terms of freeing up time for GPs to focus on medical, physical medical health issues rather than mental health issues, and the fact again that they're all either investing their own monies or NCN monies in that model. So I think what we're seeing is support being delivered through allocation of budgets and recognising what this gives to the patients, and certainly in some of the areas where we've rolled out the MDT model, then we've seen an easing of the recruitment problems for GPs in particular areas. So again, that would be evidence to support that model. And then on the wider model around the compassionate communities and the delivery of an MDT for patients, incorporating the third sector and other voluntary style services and community services, we've rolled that out, as you know, in 3 NCN areas. And again, we've had really good take-up for a further rollout as we go into next year, particularly around Newport and further south in Caerphilly. So I think it's difficult to have numerical evidence to support, but I think actually the behaviours demonstrate that this is supportive and they do see benefit from it.
Thank you. Chris?
I think Nick's answer to Tija's answered the question I wanted to ask. Thank you.
Thank you. Thank you. Shelley?
I just wanted to say thank you very much, Nick, for presenting this estate strategy for primary care to us today, and linking it with the service strategy as well, which I think is really is very, very welcomed. I think it's very clear. And I think the concerns now, or not concerns, but it would be about the capital development side of things, because I know at the beginning or somewhere through the strategy, you've got the different prioritisations. And I know we are well placed from my work on the estates group, in terms of developing that capital strategy to go and discuss with Welsh Government. So I hope, like you said, we may be a little bit ahead of the game, and, that might give us some advantages in terms of being able to carry on and develop some of the projects that are outlined in the strategy. In relation to the collaboration around estates generally, I really welcome that, Judith, because I know on the Caerphilly PSB, which obviously I and actually Nick sit on, we have got a group on estates, and it's actually one of the things that we've parked because actually it wasn't making any progress at all. So I think if there's some more strategic approach to that across the patch, I think that would be really, really helpful. And I think in terms of the conversation that we've just had around that is about perhaps there's a role for PSBs. I know there are discussions around a more strategic approach perhaps to the PSB requirements or statutory responsibilities. But certainly at PSB level, I think it's really important that all the partners around that table are aware of what this strategy entails, because there are people there, for example, Natural Resources Wales, who've got so much to offer and support in terms of, the wider health aspects. And finally, in relation to the discussion you just had around GPs and sort of their sign up to this approach, I have been able to, luckily enough, to observe quite a few NCN and the Integrated Care Network meetings, and I would say that there is a lot of support for these things. And the psychological practitioners service was something I was listening to probably about 2 or 3 weeks ago in terms of the development and integration of that. And I would say that was something that was very much welcomed. And I think my observations over the last perhaps 2 years, I've seen perhaps a change in terms of the understanding about what is on offer and where those things can be helped, particularly in those practices that are struggling to recruit or have been struggling to recruit GPs. So just really well done, Nick, and all the team for getting this where it is. Good luck.
Thank you. Paul?
Can I support this excellent model? I think it's just talks about integration, joined up, and primary care health councils and stakeholders, and in particular, to follow up what Tisha said with regard to third sector and volunteering, there's real opportunity here to get the local population engaged in this as well, because it's just about medical prescribing, it's about social prescribing and looking at the individual holistically, rather than thinking about get some tablets, they'll be better, rather than maybe ongoing issues which are involved with mental health and well-being and all sorts. So I think there's a real opportunity here for us to move this on. That's able to really. My only comment was to follow up from what Shelley has said. Could we put this particular item on all the PSB partnership agendas that are coming up in the future? Just to get a series of questions to our agency to say what are your thoughts on this, and get sign up at that level, because I'm sure from the Monmouthshire perspective, I serve on that partnership board, I'm sure that there would be a lot of support as well for this, but it would mean we could then feed that back into the system.
Thank you. Yes, of course, we will do that, and we'll ensure, as Judith has suggested, we put it on G10 as well. Emrys?
So I too want to congratulate Nick on an excellent strategy, and it's excellent how we brought together the sort of service and buildings within this paper. Obviously, form follows function, and this obviously it links into national strategy about multidisciplinary and multi-agency working. And as a number of colleagues have stated here, that demand doesn't always require a doctor, and there are other agencies that respond to meeting people's needs. How has the change? Are there any particular professionals that have struggled with the change in moving this agenda forward, Nick?
Sorry, Emrys, I missed the last bit of that question. Sorry.
In respect of our proposals going forward as multidisciplinary, multi-agency hubs, how well has the change been received by professionals, and have all professionals, are they all up for it?
So I think it's, you always get a mixed response to some of this, and I think as Tej alluded to earlier, that sometimes the difficulty in just allocating space within a building or within a particular hub can be the most problematic thing, and that can drive down morale if people, arrange a clinic or arrange a particular session. If they can't get the space that they require, it can be somewhat problematic. And I think bringing all of the services together then under a single umbrella and a single roof, if you like, in an integrated way, starts to remove some of the barriers around ownership of space, premises, etc., which can then, it enables that MDT approach really, and people become much more integrated as a team rather than their respective profession or whether they represent a particular part of our organisation or other organisations, and that focus shifts then to the public rather than organisational responsibility. So I think it is, where we've seen it work well, it's well received, and most of the profession seem to enhance and endorse this sort of approach. I think picking up a wider point around some of the well-being and mental health staff, they very much welcome this approach, and we've had some really positive feedback around how, in particular, the PWP's work, but that more foundation tier piece of work, which has resulted in a lot less people being referred into the primary care mental health service, and therefore has allowed them to almost an easing of their burden in terms of their waiting lists, etc. So I think when people start to see the results of what this can do, then obviously they engage in it much further.
Thank you. Thank you very much. Are there any further comments? Could people put down their legacy hands then, please? Well, thank you very much for that. I think it's a really, really good document on which we can build. We must take our partners with us to allow them to contribute and to expand upon these basic principles. And of course, as we go forward during the process of implementing this, we shall be able to see an evaluation of the effectiveness, value for money and improved outcomes for our populations as a consequence of this new style of services, collective style of services, and I think we'll be most interested in seeing that. So thank you, Nick, for your leadership of this issue. Might I suggest that we take the next item and then pause for 10 minutes? Is that satisfactory? Yes. Right. Nick, it's you again.
It is me again, Chair.
Primary care. And
Thank
could you
you.
pick up the point on 111 as well, please?
Yeah, so I'll cover that as part of this. So the paper that I've brought today is really about the development of an urgent primary care service, which incorporates urgent primary care centres and also the development and delivery of a contact or phone first service to support urgent care. And as you know, I mean, the board have talked many, many times about the challenges that we face with urgent care in our system, people presenting in the right places and for us to try and avoid the endless handoffs of patients to different parts of the system. So what I've tried to describe in this paper is our approach to the delivery of that first phase of unscheduled or urgent care, which is the primary care interface. And obviously with the opening of the Grange, we've sought to change the physical location of where we deliver emergency services, because we now have a single emergency department which is there to treat all the majors and 999 calls. And then we've obviously got our minor injury units that are placed around our patch to support patients who have a minor injury. What we recognised was that there are two significant gaps. The first probably is around where do you present if you have a minor ailment, which I think some of the questions earlier about the Grange probably picked up. So without the delivery of that urgent primary care service, there is an expectation for patients to be seen in the Grange for what would ultimately be fairly minor presentations. The second is the behaviour of the public and how in this age of I suppose you'd call it instant gratification, where patients are not prepared to wait, are not prepared to utilise some of the phone lines or other ways that they can access primary care, they default to our emergency departments or minor injury units. And, you know, we've presented evidence at the board before of around about 25% of all of those attendances that are outside of an ambulance could be seen by an urgent primary care practitioner rather than by an emergency department. So as part of the work with the strategic programme for primary care, there's put in place for this winter is a pace setter programme to look at different models of urgent primary care across Wales. And the model that we've presented within the paper here is one where we seek to support our emergency care system by developing two urgent primary care centres, one in the north and one in the south, which deal with patients who've got a minor ailment and can be redirected from either a minor injuries unit or a majors ED department. And the paper describes how that model works and fits together within our system and some of the presentations that we would expect to see there. And we've been able to establish an urgent primary care centre from the day that the Grange opened at the Royal Gwent Hospital, and it is actually moving today to be alongside the injuries unit in what used to be the old children's assessment unit in the old Royal Gwent front door. That unit is, so our urgent primary care centre is staffed by GPs and soon to be staffed also by advanced nurse practitioners, and we're looking at the wider multidisciplinary staffing model to potentially encompass therapies and mental health practitioners. The aim is that when patients present at either MIU or ED, they will be redirected into the urgent primary care centre, and we would then see and treat them through a booked appointment. And the evidence so far is that we see and treat everybody within 2 hours of them presenting in the first instance. The move was then to establish the same service in Neville Hall, again alongside the old emergency department, which is now an MIU, and that opened on Tuesday alongside the MIU in the old outpatients department at Neville Hall Hospital. This really is an extension of GP out of hours. So what we're looking at is a model which is 24/7 GP out of hours being available to the public to deal with their primary care or minor ailment issues. Each patient that comes in, we also flag to their GP practice so that we can start to establish a pattern of why they are presenting in this way and what we can do about improving the access in our primary care centres. But also we are looking at being able to offer appointments to local GPs in these centres so that where they have a demand that exceeds their supply, we can book those patients in for the same day so that they avoid presenting in the wrong place. So that in effect is the first part of the development. This development was approved by colleagues in Welsh Government for pace setter funding, which is laid out in the paper, and we've secured just shy of £500,000 funding for this year for this service. We will be conducting a full evaluation over the next 3 months to determine whether or not it's a model that will be then taken forward into 2021-2, and whether there will be monies from Welsh Government to fund this service on a recurrent basis. Now, what we felt that was missing really from this was the linkage to patients being able to access this service directly, which is ultimately the development of the phone or contact first service, where prior to attending any of the emergency services, that patients would ring 111, be triaged and directed to the most appropriate location. So that service in itself, we can't fully launch until January, until we've got all of the technology in place to allow that to happen. But we've been able to do a fairly quick workaround using the 111 call handlers and algorithms so that we could soft launch this service as of yesterday. So that ultimately we would encourage patients to phone 111, and any that would have a normal ED or MIU outcome from that call would be directed into a clinically manned triage hub within primary care, aligned to the GP out of hours, which would then book or direct patients to the most appropriate setting. So we can avoid patients attending or self-presenting at the wrong place. So as I say, this was launched yesterday. We've got a clinical review hub, which is described within the paper, which looks at the most appropriate conveyances, most appropriate dispositions that we can then redirect to our MIUs or urgent primary care centres. And ultimately, some will still go to ED, but we will then ensure that only the right patients attend the right places. So that, as I say, that service was launched yesterday in a fairly discreet way, and we are looking to develop a communication plan over the next few weeks so we can fully launch this service in January, so that all patients who are accessing emergency services would ring us first and be redirected. Now, I appreciate this paper is probably slightly dated because it was written as we were about to launch the services. So I just thought it'd be useful to just give you a quick update on where we are with the two developments. So our urgent primary care centres, as of last Friday, had seen 256 patients in the first 3 weeks or so. The redirections had come predominantly from the Royal Gwent Hospital and YYF. We'd had a slightly better response to redirections from the GUH last week, which we'd struggled with the first couple of weeks. But in effect, we've seen over 250 patients through the Royal Gwent Urgent Primary Care Centre in the first 3 weeks. That number is expanding each week. And in terms of Phone First yesterday, which unfortunately we had a technical issue in the morning, so we launched properly just after lunch. We saw and redirected 13 patients yesterday who would have normally attended the Grange. 5 were referred into the Urgent Primary Care Centre, 3 to her minor injuries, 3 went to ED, and 2 were dealt with through telephone triage. So I thought it was quite a positive start actually for the first afternoon, early evening of the service, and we'll obviously continue to monitor this as we go forward. So I think quite an exciting development really, Anne, in terms of where we're going with urgent care, and this really is part of that jigsaw of how we develop a new urgent care system in Gwent, and hopefully start to deliver a service that is, again, closer to people's homes, but also means that they're not handed off from one service to another.
Thank you, Nick. I think your last point is so fundamentally important. Well, it should give assurance to our communities that they can access the right care at the right time without delays, and that'd be helpful. Paul?
I'd just to say, wholeheartedly support this. I think it's very creative, innovative. It's great we've got the funding as well, and I think in particular for Neville Hall, giving that additional work there, I think gives more confidence in the community about that particular hospital. I mean, it's a great hospital, and I think there's a real opportunity for some of the work to be undertaken there, which I think is good news. And it's out of hours, it's emergency, it's all sorts of stuff there, and I think it means that it gives additionality to the current service, and it can reduce the workload on some of the GP services as well. But if we join it all up together, it's given a better service to local people, which has to be applauded.
Yes. Are there any further comments on this? Scott? There's a comment from Shelley.
Yeah, I suppose if they ring 111, Shelley, then they're likely to be directed to, if they were triaged in, if their normal outcome would have been ED MIU in our area, then they would be triaged into that service.
Oh, sorry, can I just follow up on? I think it's Shrop Doc, but that might be only out of hours, mightn't it?
Yeah.
It's just an interesting one because there are quite a lot of people that would certainly have turned up to Neville Hall,
I need
previously.
to double check, Shelley, really.
It was just if you could and just send me a note or whatever, that would be helpful. Thank you.
Thank you. So we endorse the Urgent Primary Care Services paper, and we look forward to receiving additional information on how Phone First is working and how this whole system is meshing together to ensure people get to the right places. Thank you. Right, can we have 10 minutes break, please?
duties under the Nurse Staffing Levels Wales Act, where we're obliged to report annually on the nurse staffing calculations. The board will be, The board will be aware that we need to report under the medical and surgical wards. And this is important based on legislation. The calculation of the staffing levels and the acuity assessment has been really challenging this year, mostly as a result of COVID, but additionally because of all the ward repurposing that's had to happen, and that's been ongoing in earnest since the beginning of the pandemic in March. The situation has been very fluid, and naturally comparisons to the acuity and the recalculations that we've undertaken previously, and particularly last year, we're not able to do a direct comparison as a result. The board paper includes a summary of the ward establishments, but additionally an overview of all the repurposing that we've undertaken and an analysis by ward. This was a new requirement based on the letter that we had from the Chief Nursing Officer in March, when health boards were asked to consider the position in terms of nurse staffing and a disruption to the requirements of the Act. And board members will recall that we took that paper to the executive team, and there was a chair's action in relation to the position with nurse staffing. Just by way of reminder, we deferred our annual reporting, which would normally have taken place in the spring, but we agreed to continue to undertake the acuity auditing in the summer. That acuity audit has taken place, and I think the appendices outline the wards that we've reviewed, undertaking the triangulated approach that's identified as part of Section 25B of the Act. And this is where we undertake an acuity audit, so we review every patient on the medical and surgical wards, identified using the Welsh Levels of Care tool. We undertake professional judgment, which is with the nursing team, the ward sister, senior nurse and divisional nurse, and undertake a review of the metrics, which have been again identified as part of the Act to review patient outcomes. In January this year, before COVID, we had undertaken the acuity audit and the biannual calculation, and at that time we reviewed 29 wards. I think that the appendice belies really the significant amount of work that is undertaken to do this triangulated approach. In the summer, we reviewed 32 wards, and that's because of the additional capacity that is open. But when we've analysed those areas as part of the definition, there were only 2 wards that were excluded on this occasion, and that's because the wards were high acute respiratory. We've had the respiratory wards previously, but because they were classified at that time as a medical ward, they were included previously. But on this occasion, because we've got such high acute care, that they're not classified as part of the Act definition. So there are a number of requirements in terms of the Act. We are required, I think, particularly for this paper, we're required to calculate the staffing levels for the medical and surgical wards, and we're asked to take reasonable steps to maintain the staffing levels. So for the purpose of this paper, I can confirm that the staffing levels have been reviewed using the prescribed triangulated approach, and that the levels have been locally agreed and they are fully funded. I confirm that reasonable steps have been taken to maintain the staffing levels, although the board are fully aware that we've got significant deficits in terms of registered nurses, but additionally healthcare support workers at this time. We had, as Geraint mentioned earlier, a significant vacancy factor pre-COVID, and this has been significantly impacted as a result of COVID during this year. We also, in March, undertook a review of the staffing levels that we felt were appropriate based on professional judgment as a result of demand and supply. And those levels were agreed, and as a result of the acuity audit undertaken in the summer, we are continuing with those staffing levels as we move forward. So the acuity review and the recalculation that's been undertaken in the summer has been approved locally. I have signed that off as the designated delegated responsibility. but wanted to draw the board's attention to the work that we're doing to redesign the wards, allocate new roles to support the wards, particularly at this challenging time. We've talked previously about the core care team, but additionally we've appointed additional ward clerks, ward assistants and runners for the ward just to help whilst we're in a very challenged position. Our mitigation previously was in terms of overseas nurses, and the board will be aware that we, as an exec team, approved an additional plan to secure more overseas nurses. But that mitigation was halted due to COVID and the restrictions in terms of travel. Whilst we have now been able to recruit a number of overseas nurses and have a very successful campaign in terms of them getting on the register and NMC approved, we still carry a number of deficits. We also have progressed to using off-contract agency nurses for both registrant and healthcare support workers at this time to ensure that we are maintaining our staffing levels as safely as possible. I'd probably just draw the board's attention to the comments that Sarah made earlier as well in relation to ensuring that the capacity that we have open in terms of beds, particularly in the acute sector, are matched to the staffing that we can safely supply to ensure adequate standards of patients' care. I think that the acuity audit and the recalculation and the ongoing staffing challenges has been incredibly difficult this year. Board members will know that this is identified as a high risk on the corporate risk register. Our senior nurses and divisional nurses are spending considerable time reviewing and redeploying staff on an hour-by-hour basis as a result of the demand and the repurposing of wards. And we constantly review the patient experience, quality and safety metrics that we have. Board members, IMs particularly, will be aware that we've developed a COVID dashboard and we review that weekly in the executive huddle and share that at executive team. The paper also highlights the work that's ongoing in relation to the extension of the Act. And whilst we're in a very challenging time within the UK and Wales, there is ongoing work to extend the Act, particularly to paediatric services, acute paediatrics. And we've recently concluded nationally a consultation on extending the Act to paediatrics. And there's ongoing work in terms of district nursing and mental health nursing. So we're required to undertake a further review of the acuity and recalculation of levels in January. We are anticipating that's going to be considerably challenging, and I am in discussions with Director of Nursing colleagues and the Chief Nursing Officer about that requirement. We're anticipating that January is going to be a very pressured time. So based on the report, I am recommending to the board that you improve the staffing that's been agreed through the acuity review and the biannual calculation, but also the implications of COVID on our staffing levels and, of course, patient experience. Thank you.
Thank you, Rhiannon. That was very clear. Has anybody any questions, or do we wish to support this report? Yeah. I think it would be helpful. Thank you, Rhiannon. And Emrys?
You're on mute, Emrys.
My apology. Two questions, Chair. In relation to the how the demand, there was a professional judgment done on the staffing levels, undertaking the staffing levels in the summer based on demand and supply. Is that significantly different to the actual guidance that we should be working to?
Yes. Well, the guidance, they don't specify the numbers of registered nurses or healthcare support workers that you should have per ward. That is down to professional judgment and the acuity. So whilst this has been undertaken, the acuity review was undertaken in the summer, I can assure the board it happens virtually on a daily basis. So we have to report these biannual calculations, but it happens daily. So for example, yesterday I had escalated to me the issues within respiratory at the Grange University Hospital. And as a result of that, we've already undertaken a review of the patient acuity and confirmed that we require additional nurses, additional registrants at the GUH to accommodate that patient demand. The levels that we have proposed absolutely changes. So if we compare to where we were 2 years ago, for example, on a general medical ward, you'd have probably 5 registered nurses. And at the moment on some of our wards, we have 2 registered nurses per shift. So there is a significant difference, but we've had to be pragmatic based on supply and demand.
Sure. Thanks for that, Rhiannon. My second question is that are we doing a similar piece of work for the senior nurses that are required to deliver services as well?
Yeah, absolutely. So over the past couple of weeks, we've been looking at the support that senior nurses require because the staffing challenges and the review hour by hour is so demanding. So we are looking at the support of senior nurses for that. I think that's particularly important in the out of hours period as well, and particularly on weekends. So we are exploring how we can support that, which doesn't necessarily need to be with nurses though. So the role of the workforce and OD colleagues and the business partners across workforce and OD is critical, as well as roster creators. There's a significant amount of work that happens in terms of electronically reviewing the numbers of staff required. And again, the board will be aware that as part of our approach to the core care team, rather than the ward sisters and senior nurses spending a lot of their time looking at the rosters and reviewing the rosters, we've created a new role, which is IT focused, that can help with that. So we're looking at every opportunity that nurses only do what nurses need to do, and others are brought in to assist.
Thank you, Rhiannon.
Thank you, Rhiannon, and I would agree with that approach. And I think that for the future, we'll have to have a discussion about this important act and the consequences of when we're starting to reassess our skill mixes on wards for the future. Thank you. Okay, so we accept this and submit it. Thanks. The risk insurance report, Judith.
Thank you. Thanks, Chair, and thanks to Richard Howell, who's liaised with the execs in the preparation of the report. This report sets out the strategic risks of the Health Board. As you'll know, these are regularly considered at the board's committees and at our executive team, which is responsible for ensuring that the corporate risk register is reviewed and updated. And beyond this risk register, there are a range of risk registers held in each division, in many departments, and of course you will know that individual and specific projects that we're working on also have risk registers, and these are brought together, reviewed on a regular basis, and inform the corporate risk register that's attached today. I think the other thing to just remind the board and those members of the public who might be listening, that the organisational risks are actively used to inform the setting of the agenda for the board and the committees of the board. And just to pick a couple of examples of the issues that are in the paper today, the risk related to the failure to reduce healthcare associated infections was discussed at the last Quality and Patient Safety Committee. Clearly, we've had a discussion today about nurse staffing levels, and later on in the agenda we'll consider a paper on the UK leaving the European Union. So it is really important that the issues identified as risks do flag the agenda and inform the agendas of our board and committee work. In relation to the risk register today, there have been some changes since the last time we reported this to the board. You'll note on page 3 of the report, or page 265 of board books, that one risk has an increased score. So the risk that I mentioned just a moment ago, the failure to reduce healthcare associated infections, we have increased that risk. Not only related to some of the outbreaks that we have experienced, but recognising that as the increased community transmission of COVID is experienced across our health board area, the management of that within a closed setting becomes more difficult. So that risk score has increased. And then we have reduced the risk score relating to the poor update of the flu vaccination amongst our staff particularly. The paper makes reference to this being monitored on a weekly basis, and the figure in the report, which I think has not been updated since the last report, talks about the uptake in the 2nd of November, but actually at the 9th of December the update was 63.2% amongst our staff, so that just reinforces that that's appropriate to reduce that risk. But just to say that is being monitored weekly. All the executive leads have reviewed their individual risks, and the collective risks have been reviewed by the executive team together. And as I said earlier, individual committees have had the opportunity to discuss either the risk register in its entirety, like the audit committee, or specific risks that relate to their own committee business. Other than that, Anne, I wasn't going to say any more. Ask the board if they would consider and note the report. Thank you.
Thank you very much. Are there any questions to Judith? I know it has been discussed extensively at our committees. Okay. Thank you very much. We accept that report. The finance report, Glyn.
Okay, thank you very much, Chair. Just a couple of points that I really want to draw out of the finance report. I think it's quite pleasing to be able to present what I think is quite a positive position with regards to funding and financial position within the Health Board, and probably important to acknowledge that I think we've had some excellent support from Welsh Government during the COVID pandemic. As we've gone through the different stages of the pandemic, we've worked very closely with Welsh Government to identify some of the pressures that we've had to deal with in response and what the financial consequences are. And as we've gone along, I think they've been really, really helpful and supportive in the way that they've secured funding for us. And in some ways that reflects where we are now in terms of reporting the sort of year-to-date position, but also a forecast of break-even for this financial year. The report that you've got in the papers is based on the end of October, which is our sort of month 7 position. Since that time, we've finalised and reported the position for the end of November, which is month 8, where we reported a surplus of £572,000 year to date, and we are forecasting financial balance for the end of the year. What we've seen over the last few months, I think, is, has been described before in service and workforce terms, we've opened the Grange University Hospital early. The commissioning costs that we'd originally planned around the opening have turned out to be lower than expected, and I think that's in part because of the truncated timescale of opening the hospital ahead of time, but that I think is positive news. And also what we're seeing in terms of workforce are generally workforce costs are lower than we'd originally planned or provided for in areas like contact tracing, but also in some of the surge plans that we've had to implement as well. So that's reflected in the financial position to date. It's also reflected in the assessment that we've done around what level of revenue funding we think we need for the remainder of this year. And this is quite an important point of the year in terms of agreeing this with Welsh Government, as they clearly need to also sort of determine what level of funding they need to secure for the NHS for the remainder of this year. So the paper sets out some of the changes that we've seen around some of our assumptions, and as I mentioned, the early opening of the Grange Hospital was one of those areas. There are a few other areas where during the course of the year we've made provision for different things that we thought may happen based on the service and workforce plans that we had at the time. And obviously some of those assumptions have changed. So where we previously estimated and made provision for things like pathology costs, the level of spend on that is lower, and we believe will stay lower than we'd originally estimated. So we've reflected those in our assessment of what we think we're going to spend during the rest of the year, and therefore what level of funding we think we need to secure with Welsh Government. So whilst I think the report is generally a positive one, I did want to take the board through some of that in terms of the paper, so that the board are clear that we will effectively be fixing a level of revenue funding now, which we will need to manage within for the rest of the year. Now, just for some assurance, we have built into that some flexibility, so we know that we will be looking to commission further elective care with the independent sector during the remainder of this year. We've built in flexibility to cover that. We've built in flexibility around some variation in things like workforce costs, the cost of doing more patient testing and staff testing. So we've got a level of flexibility, I think, within the position that we're forecasting that means we should be able to manage most of those things as we go ahead. After this meeting, we will then formally be writing to Welsh Government to confirm the funding levels and some of the assumptions that we've made, so that governance is very clear with Welsh Government. There are a couple of areas that we've sort of highlighted that we feel are probably risks that potentially could be outside our control. One that we discussed at the audit committee was around if we find that we have to make a financial provision around carrying forward annual leave, particularly if that's a material level of annual leave, but that's something that we haven't got financial coverage for, and we've already had separate discussions with Welsh Government about the potential for doing that separately. And then I guess the second part is any material policy changes that Welsh Government implement subsequently that we wouldn't necessarily have had plans for or covered. Our assumptions include a level of funding for the mass vaccination programme, so we've assumed that the costs of that programme will be covered through a separate funding allocation, which we've identified and we will identify when we write to Welsh Government. So as I said before, I think it's generally positive. The support that we've had to date from Welsh Government has been really helpful, and look forward to that continuing. Final point that I just wanted to raise was around capital funding, because I know in the report it talks about a potential deficit at the end of the year. This is more, I think, about timing of actually formally agreeing funding with Welsh Government on some of the capital spend that we've incurred during this year. So not just around accelerating the opening of the Grange, but also some of the surge capacity and capital expenditure that we've incurred elsewhere in the health board as part of our response to COVID. And since this report was produced, we've received an additional £1.3 million of capital funding, which is related to COVID spend, and we're in discussion with Welsh Government about just trying to finalise some of the capital funding for this year. Some of that is linked to really just sort of finalising some of the numbers around the Grange Hospital now that it's opened. So again, I don't think there are I've got no major concerns about us being able to manage within the capital funding that we've got allocated and what we're likely to secure in the next few weeks with Welsh Government. I think the final point on capital, which I think is a really good news story, is Nicola mentioned earlier that we've opened the Grange University Hospital ahead of time. I think it's also important to say that we will have also delivered a major capital scheme under budget as well. So I think it's a tremendous achievement for everybody in the health board, those involved in the construction of the programme as well, in actually delivering it ahead of time and the budget, and in the pandemic. So a real achievement there, which I think it's important that we acknowledge at the board. So happy to pause and take any questions. Thank you, Chair.
Thank you, Glyn. And this is certainly a more positive picture than I think we could have expected. And well done on your negotiations and their success with Welsh Government and for their support for us. Any questions, Paul?
Yeah, can I just say, I mean, it's been an incredibly difficult time for everyone, and part of our role as a board is to ensure that we, in terms of finance, we are both efficient and effective. And of course, funding is of vital importance, and I think that this is a very, very positive report, and huge thanks to Glyn and the team with regard to that. And I think there is an opportunity, and when you have an opportunity, to actually say thank you to Welsh Government for the support we have received in Gwent for the various projects, in particular the early funding of the Grange, and I think we emphasise the fact that it came in under budget. We've got some really exciting and creative plans and innovative plans for the future, and we look forward to future support for that funding.
Thank you. Rhiannon, did you want to add something?
Yeah, I wasn't going to question Glyn on the finance, but I just wanted to highlight the link between what's been identified in the paper in terms of off-contract registered nurse agency and the alignment to the previous paper, in a way of providing assurance that we are doing everything we possibly can to ensure the adequate staffing, whilst we recognise and for years worked so hard to eradicate agency nurses from this organisation. Is somewhat sad that we're in the position where we're using agency nurses that are on contract, let alone off contract, but it's the position we're in, unfortunately. What the table does show on page 4 or 272 is that we're still using a large amount of on-contract agency with a small amount of off-contract, with the exception of the position in the summer, which I think again just demonstrates a significant amount of work to try and secure the right staffing for the ward areas. Thanks.
Thank you, Rhiannon. Chris?
Yeah, thank you. And I'd support what you, Anne, and Paul said about the good work that Glyn's done as Finance Director in working with Welsh Government, but also the whole exec team in the way that they've been able to demonstrate and get confidence from Welsh Government on what we're doing. I just wanted to pick up one point that we discussed at the Audit Committee, so the board is aware of it. In the paper, it refers to opportunities for efficiencies around the introduction or implementation of value-based healthcare. And Glyn, you gave the Audit Committee some positive news around how we're going to take that forward, particularly next year, which is probably worth sharing with the board.
Yes. So, I mean, most board members will be aware that some of the priorities that we identified in the IMTP at the start of this year was around taking a value-based approach to the way that we deliver care, particularly focusing on areas like musculoskeletal and eye care. And I think that represents a great opportunity, particularly now, I think, when we've seen quite a shift in the way that we're delivering some of our services, to actually look at alternative ways of providing care to people. And I mean, the next agenda item will identify some of the performance targets and where there are an increasing number of patients waiting to access sort of surgery. I think the value-based program that we're taking forward will actually offer alternative opportunities for patients to access care that will actually improve their health outcomes. So at the last Audit Committee, there was a presentation on how we're looking to implement a more integrated approach to eye care services in the Health Board. And we will also be looking at musculoskeletal services at the next Audit Committee. But I think this is very much the start of an increased emphasis on how we apply value-based healthcare principles to the way that we deliver care and make better use of our resources. So this represents, I think, a significant opportunity to actually look at how we reallocate the way that we use some of our resources across the Health Board area. through the audit committee, we will also be looking at a number of other areas of efficiency and how we deliver more effective use of resources as well. So I think during the course of the next 6 to 9 months, the board can probably receive further updates from the audit committee on progress that we're making on this. But I think COVID and the pandemic actually gives us an almost unique opportunity to look at how we do things differently. And I think the comments that we made earlier about doing more video consultations for patients demonstrates one of the ways that we're using technology to deliver care differently. So I would agree with Chris. I think there are some really great opportunities to push forward on this in the next few months.
Yeah, it's really important that we do that, Glenn. Are there any further comments? Well, thank you very much for that explanation. And go on to your performance report, please.
Okay, thanks very much, Chair. I'll keep this fairly brief because I know there's a lot of data and information in the report. I know that it was mentioned earlier that the Health Board had obviously had to make the sort of difficult decision of postponing some of our non-urgent outpatient clinics and planned surgery from this week. However, as a Health Board, we do have arrangements in place with the independent hospital sector to deliver some elective care, and we will, for instance, be continuing to commission ophthalmology treatments with Care UK for our patients. So I think it's important to understand that we are doing absolutely everything we can to try and continue some of those elective care services whilst dealing with a lot of the pressures that have been described earlier. Board members will see that in some of the performance figures, waiting times and the number of patients who are waiting for elective care have increased. However, I think where we've been able to, so in areas like diagnostic interventions, therapy interventions, you will see that actually, despite the numbers having increased during the COVID pandemic, we are now actually making inroads into addressing some of those backlogs. So I probably don't really want to say a lot more than what's covered in the paper because it does set out briefly the actions that we are trying to take across the range of our services to try and make sure that we still deliver good, high-quality care to our local population. So happy to pause and take any questions that anyone has.
Thank you, Glenn. Are there any questions or comments? No? Well, perhaps I might say that obviously there are a number of items within this performance report that we need to improve on, and we understand very well why we've not been able to meet our requirements, which we set at the beginning of the year. But I think it'd be helpful if at our next meeting we could have an update on the single cancer pathway and how that is proceeding, and also our action plan for stroke management. As we know, these are very high on our agenda. Is that all right?
Yes, that's fine.
Thank you. Thank you very much. Okay, if we pass on then to the mid-year review of IMT priorities, and I think this was quite a heartening report because it showed us that we'd actually achieved more than I think that we had the nerve to expect, really. Nicola.
Thanks, Chair. And yeah, we whilst the fact we paused the IMTP, I think we felt it was important to do the mid-year review of the 10 priorities that we had set out for this year as a board at the end of last year. And I think it is quite a good item to have towards the end of the agenda as a bit of reflection about what we have achieved over the last 6 months. And I think what the report shows is that the pandemic has actually led us to escalate and go at a greater pace or with greater focus on some of these priorities. While some of them have change their focus slightly, and others will become even more important as we go into next year and hopefully at the other end of COVID. So I won't spend too long on them, conscious of time and the detail in the report, but I'll just pull out a couple. So obviously the workforce one in particular, where one of our key priorities was around being as innovative as we can in the context of the workforce challenges, and also our commitment to the well-being of staff. And I think, starting with the first wave, the way that we had to respond from a workforce perspective to respond to the pandemic was unprecedented and worked in an innovative way beyond, I think, whatever any of us would have expected at the end of last year. And, I think the workforce cell was set up. We redeployed people into different areas out of their comfort zone. And we all, the fact we're all here now on a Teams call shows we've had to work in much more innovative and digitally enabled ways. And also the well-being, as Gerard mentioned earlier, we were committed to well-being before this, and I think it's highlighted even more important now as we support our staff through the remaining months of the pandemic and how we support them as we come out the other end. We know all the evidence that suggests this is going to be a huge requirement for us to continue to focus on. The second one, which was around opening the Grange Hospital, we did that in the context of opening it in March, and we went from opening, having access to half the hospital at the end of April to be able to meet surge. It helped some of the planning work we had done around the new models of care we managed to benefit from during the first wave, and as we know, we've just opened the hospital 4 months early. I think under urgent care, the way, we had very specific priorities at the beginning of the year under this heading, but the way urgent care has had to respond in getting separate streams for meeting the demands on urgent care at the front door was quite phenomenal, really. And I think picking up some of Nick's reports earlier on, now looking at how we stream patients appropriately and give them access to different services at the front door is a key priority for us now going into the next 6 months. The value-based pathways, we've had to respond differently using digital as much as we can, and these will become particularly more important now in terms of the recovery in the context of some of the backlog that Glyn was just describing, and we are going to have to work differently and really embed value-based pathways given the scale of the challenge we've got around that. I think both the care aims one and the integrated wellbeing networks are hugely relevant and have just kind of given it a whole new focus really in terms of what matters to patients and also how we embed those wellbeing networks, and I think has just given it a whole new focus really as we move forward. The 10-year plan, which actually should say Healthier Gwent, I think the G10 agreed that we needed to pause that work, but the focus now on the 4 harms, and I know Sarah said this and it's in the report, that the concerns that we will increase that gap in the inequalities as a result of the pandemic, which will make this an even more important plan as we go into next year. Mental health, obviously we continue to, through essential services, to make sure that we keep our focus on mental health and particularly the crisis service. And Judith mentioned it earlier around maintaining our CAM services. I think we've also been doing a lot of work in mental health around support around the wellbeing practitioner, trying to predict the demands on mental health services now as we come out and continue through the pandemic. The cancer strategy we've picked up in a number of conversations today. It has been a continued focus and priority for us through the pandemic. We've done, I think, particularly well in meeting the needs of our cancer patients and accessing those essential services over the last 6 months. And the Cancer Board has been established under Sarah's leadership, and we've now set up a number of new initiatives around vague symptoms clinic, use St. Joe's as much as possible. So I think it kind of emphasises the importance of cancer now and going forward. And then finally on the estate strategy, we've approved the energy strategy at the September board and have made good progress across 4 of our key business cases, from breast services, the satellite radiotherapy and the 2 primary care centres, despite being in the middle of the pandemic in the last 6 months. So I think across the board of the 10 priorities, there's been some significant achievements across those, and some have had a completely new meaning, I think, and also frames the areas we've got to really focus on now as we go into 21-22. Thanks, Chair.
Thank you very much, Nicola. Are there any questions to Nicola? I think I have to re-emphasise that, this is really helpful, and it does show that we have managed to achieve much despite the extreme pressures that have been placed on us. So I think it was a very, very helpful report indeed. Many thanks. I've got to find the agenda. Where are we? Oh, EU transition.
Thank you, Chair. I'm sure we've all seen the news over the past few weeks on the status of the negotiations with the EU. Therefore, the Health Board is still needed to assume that no deal will be reached at the end of the EU transition period. And this paper is to provide assurance of the ongoing preparations that the Health Board has been undertaking with partners, which are in line with the reasonable worst-case scenario planning assumptions. The paper provides a reminder of the national, regional and local activities during 2018 and particularly 2019. You might recall the distinctions between those matters that are negotiated by the UK government, then again on an all-Wales or regional basis. These have been part of previous exec team and board papers, the last being in September 2019. They contained at that point our best assessment of the potential risks and the action we were undertaking locally to mitigate. That assessment of risk was also submitted to Welsh Government. From October 2019 to September 2020, there was no further activity, but now that we're nearing the end of the transition period on 31st of December 2020, and given the speculation that no deal might be agreed, there was a standing up of all national, regional and local meetings. Appendix 1 shows the groups in place and the reporting arrangements and overall governance framework. And the Health Board with partners has revisited the theme, workforce, procurement, medicines, equipment and machinery, research and collaboration, ICT, finance, public health and capacity, and these are all set out in Appendix 2. If I may, Chair, I'll just highlight a few of those areas in Appendix 2. So workforce, the Health Board employs 176 EU nationals, with the biggest grouping being in medical and dental. Workforce business partners have continued to work with divisions and individuals on settled status arrangements. Newfield's law will support the more complex cases, and staff have until June 2021 to apply. Social care have not reported any issues within Gwent, with less than 3% of workers being from the EU, and no issues have been registered with primary care contractors. Procurement. There have been concerns over food and food prices. Suppliers have been asked to increase stock holding and also build buffer stock of certain foods, both at the central warehouse and at the national distribution centres. As a belt and braces approach, emergency planners have also been asked to reconsider the plans that need to be put in place should a major distributor collapse. That said, there is a high degree of assurance in terms of the kind of supply chain that is in place and the buffer stock that is, as I said, arrangements are being put in place. Medicines, considerable work has been undertaken by Welsh Government. 60 short supply medicines have been identified. However, the Chief Pharmaceutical Officer is not concerned that these will present serious problems because substitute products exist. The Health Board has also continued to keep stock levels high. Informatics, so this is an update on Appendix 2. Much of it is being managed on an all-Wales basis. However, locally the team have now reviewed data assets, and these have been assessed as low risk. And lastly, capacity. We've talked on other papers in today's meeting about the various asks on the workforce, and of course any impact of aspects associated with EU transition might be a bigger ask, and will be generally kind of involving the same sorts of people. So that's something we need to continue to monitor as we go through the next weeks and months. As with the previous arrangements in 2019, there will be daily exception reporting. So this will see the Health Board reporting to the Local Resilience Forum, and onward to Welsh Government, and then through to National Government. This exception reporting will go live on the 28th of December. We've also recently received proposed communication timetable from Welsh Government, referring to key messages and preparing Wales information. These messages have been centrally developed and will be put on the Welsh Government's Preparing Wales website, as well as the Health Board's intranet and internet. And finally, clearly there is a lot of information contained within the report and in the appendices, and the report is written at a point in time. We will continue to monitor the situation, take action, and escalate any issues as necessary. The board is asked to receive the report for assurance, and I'm happy to take any questions. Thank you.
Thank you, Deborah. That was very comprehensive. Are there any questions to Deborah?
Nobody has a question or a comment. Thank you.
Yep.
Thanks very much, Jess. It's a really comprehensive paper. Recognising the element in terms of a RAG rating of green for EU staff, particularly for agencies, and our use within the Health Board, I just wondered on a more from a partnership perspective, if we've considered that for care homes. I'm just very mindful of the fragility of the care home setting, and whether that's the case, that it's not so much EU nationals working within the care home setting as well.
We have tested that out, Ree. So we've got local authority partners who sit on our internal EU transition group, and I've also been to meet with directors of social services. So the assessment that we've got within Appendix 2 has been signed off by all of those partners, who are not raising any additional issues around agency workers within the care home sector, being EU nationals.
Okay, thanks, Deb. Thanks, Chair.
Well, and I am really pleased that we are helping our EU staff with applying for settled status, as it is a very complex system indeed. So, and help is required to be successful. Thank you. If there's nothing further, okay. Key committee issues. Start with planning. I have nothing more to comment on. Much of this has been picked up in our board meeting today. Are there any questions to me? No? Okay. Shelley, Audit Committee?
Yes, Anne, there's two Audit Committee or assurance reports. There's nothing I want to raise on the first one in October. And just on the second one, it's just leading on from the risk report that we had today. We've agreed that some members of the Audit Committee will meet with Glyn and the Board Secretary so that we can develop the Board Assurance Framework, so that hopefully by March we will have something that we're confident will take us through through the next period. And we did obviously raise risks in relation to infection control and the care home sector one, which we certainly dealt with that. Thank you.
Thank you very much, Shelley. Well, we look forward to hearing the report on the outcome of that discussion. Emrys and quality and patient safety.
Yeah, just one point. Excuse me, just one point, Chair. As a consequence of service demands, the quality and patient safety agenda was modified to focus on the COVID risks. A follow-up quality and patient safety meeting is being arranged for January to assure the usual quality and performance reports we review.
Thank you. Any questions to Emrys on that? Okay. And then we have two reports from the Welsh Health Specialist Services Committee, October and November. Are there any issues arising from these reports?
Nothing I want to bring to the board's attention, Chair.
Right. Thank you. Thank you. Any questions? No? Okay. Well, thank you very much for your attendance and your attention this morning. It's been quite a long meeting, but I hope it's been informative and that we've discharged our responsibilities appropriately. So the date and time of the next meeting will be Wednesday, the 27th of January at 9:30. We will now go into our confidential session in 2 minutes, please. Thank you.